Can you still see the slide, Lisa? Okay.
I can.
Okay, perfect. I had a weird window pop up, so. I am ready whenever you all are. You want
Sounds
to give
wonderful.
a few more people more time to arrive, whatever you all want.
If you're ready, I say we get started. We have this recording. Um, and we already have 45 individuals joining us today. So,
Nice.
all right. Well, good morning. Thank you, everyone, for joining us virtually for our Zero Suicide Initiative series. This is Anna Seaver, the Tennessee Suicide Prevention Network Executive Director. It is my honor and privilege to introduce Anna Lieber, who is an incredible suicide prevention expert, and she is supporting us to learn how to integrate suicide safer policies and procedures into our organizational practices. I attended one of Anna's sessions at the American Association of Suicidology conference a couple of years ago and was inspired by her work. And I am so grateful that she is here today to support our organizations across Tennessee adopt suicide safer practices. Of course, I'll allow Anna the space to introduce herself more fully as she would like to, but I did want to go over the structure of today. So this morning session is geared more toward behavioral health clinicians and personnel, and there'll be a content session for the next couple hours. And once the content is presented, there will be an hour where Anna will take questions and offer T&A. We will then break and resume in the afternoon with the same structure. However, the content will then be geared more toward the physical health side of clinical care. And with that, Anna, thank you again for being here today, and the floor is yours.
Great. Thank you all so much. And thank you, Anna, and the entire Tennessee Suicide Prevention Network. Um, just a couple of kind of housekeeping, I guess, items. Please feel free to use chat as I present today's topic. We will go for about 90 minutes. I have quite a bit of, I wouldn't say dense, but content regarding this topic available. And my hope is that we can engage via chat. So feel free to use chat if you have specific questions. I would ask that people stay muted. You're welcome to be camera on or camera off. That's up to you. During our Q&A portion, we will be able to actually converse and have a conversation, as well as dive a bit deeper into some of the skills I'll be touching on in this morning's presentation. The behavioral health presentation will be, it's actually a case study presentation. So I do think while there may be a few overlapping concepts, it is quite different in some areas than we'll be presenting this morning. So if you're able to attend both, I think you would get something out of both, no matter where you're working or in what capacity. Diving in, just the disclaimers. Really, today's topic really is focusing on the persistent suicidal wish. And really, there is a lack of research, although it has increased exponentially over the past 15 years. But we cannot say with certainty what is or is not happening with individuals who experience a persistent wish to die or chronic suicidal behaviors. So I just want to acknowledge that. I and others must theorize, extrapolate, and rely on my own clinical case studies and experience. Everything I'm presenting today is mentioned in the research literature from various suicidologists like Dr. David Jobes, Marsha Linehan, Janina Fisher, Joel Paris, and others. However, I have extrapolated some of their findings and theories and often read between the lines to create an understanding of chronic suicidality that makes sense both to me and most importantly to my patients, with the goal of being more effective in providing a therapeutic space where my client is able to heal. We will also, I will have a handout that will go into this in more depth and include resources and all of those. And that handout will be emailed to you all probably sometime next week. Also, everything I'm speaking about today is based in general guidelines and skills, and it's important to remember that they are not prescriptive for any one case. Although it's grounded in research and best practices, no guidance can outweigh the information you and your patient have about their individualized situation. So I encourage you to adapt these skills to your own clinical orientation, comfort level, and capacity that your client may have. Learning objectives. Also wanted to touch on zero suicide, which is an extremely important movement in suicide prevention spaces. Today, I'm specifically going to be focusing on the zero suicide core concepts of identify, engage with the suicidal wish, treating suicidal individuals in clinical interventions using evidence-based practices, and we will touch on transitions in care and obviously training, which you all are participating in today. So just wanted to name that although chronic suicidality, I think fits nicely within the zero suicide framework. And I encourage you all to learn more about zero suicide and all of the resources that they offer. May is Mental Health Awareness Month. And to me, it's important to remember as we focus on suicide prevention efforts to also acknowledge and honor. I think especially I can't do a presentation without thinking about the individuals who are struggling with suicidal thoughts, those who have been lost to suicide, the suicide loss survivors, including clinician survivors. And I think that it's important to recognize that many of us in this virtual space or watching later on demand are individuals with our own lived experience. We may be suicide loss survivors, clinician loss survivors, or care about someone who is experiencing suicidal intensity. By virtue of attending this training, we are all interested in embracing this work in managing both the pain and joy that comes from engagement with the suicidal wish. A little bit about me and why I do this. I've been working in behavioral health for 25 plus years. I am a licensed clinical mental health counselor. And for the past 15 years, the majority of my clinical practice has been in treating suicidal behaviors and trauma from all levels of care, from outpatient to intensive outpatient and inpatient settings. But I think more importantly, I've been living with the devastation of the suicidal wish all of my life. I am a suicide loss survivor. Close friends, family members, and clients have died by suicide. Suicidal behaviors have been present in my family intergenerationally. I am also a person with my own lived experience and have struggled with my own suicidal wishes. I was the chief clinical officer of a large psychiatric hospital, which began about 15 years ago. And in that role, where the majority of the patients, both inpatient and outpatient, were struggling with suicidal ideations and behaviors, I realized very quickly that I had to do something different to meet their clients' needs. And that's really when I began my deep dive into training, learning, and better understanding the suicidal wish. The ways I had been taught to manage suicidal ideation and intent were not working, both for me and for my clients. So I learned from the experts, got my own training, and trusted in my own and my clients' experiences to find a different way to help my clients manage their suicidal thoughts. And I hope to share with you all today a piece of that journey, and maybe encourage you all to look at things a little differently. Before we can work with anyone experiencing a tremendous level of pain, such as suicidal intensity causes, I think we have to first look inward. So if you're comfortable, I would ask you to put into chat what common emotional reactions or thoughts do you experience if you are working with an individual who is suicidal or who has a persistent wish to die. And I'll give you all a few moments just to type into chat if you're comfortable. I see sadness, hopelessness, pressure. Oh, that's a good word. Worried, anxiety, isolation, feeling so alone, urgency, fear, lack of resources. The most common emotional reactions are these, oh, defeat. Yeah. It's fear, right? I mean, and I still experience all of these. Fear, anger, helplessness, hopelessness, frustration, sadness, burdened, not valued, empathy, yeah, overwhelmed. Yeah, I'm thinking about this not valued. And it really can feel that way, right? Especially even with clients, but especially with loved ones. We think, how can you not care about me, right? It can feel very hurtful when someone we really care about wants to die. I just want to normalize that all of these emotions are completely normal. And what's interesting to me about this is often how our clients feel. So we tend to react with the same emotions that our clients feel. To manage this work and to bracket, right, to keep our emotions out of it, one way to do that is to really ask yourself, what is it about your beliefs or views about suicide that create this intensity? And what is it I tell myself about suicide that drives what I do? Um, and I see someone mentioned the client feels burdened. Sorry, I think yes, clients do feel burdened, but I also believe that clinicians often feel burdened, right? It creates a tremendous amount of work when have a client who is acutely suicidal. It can feel burdensome to us as well. I think that is a very normal reaction. What's important about looking inward really is this. Research shows that our ethical, moral, and philosophical conceptualization of suicide has a direct and indirect influence on our clinical practice. And that makes sense, right? If we're operating from fear-based practices, that shows up in our clinical spaces. And the fear of this is that if we bring our social roles, our own anxiety and fear into the space with our clients, we may be inadvertently repeating the problem, right? We may be reinforcing those suicidal thoughts. And that is the opposite of what we often want to do. So really this kind of self-monitoring becomes an important key into providing suicide focused care. When I think of all these emotions that I experience when my patients are struggling with suicidal intensity, I think of it as the suicide anxiety, which is a different level, at least for me, of anxiety than I may experience with other clinical presentations. So when I'm going to encourage all of you today and me to ask ourselves, what frightens you or makes you the most uncomfortable when treating a client with chronic suicidal behavior? And that is that persistent wish to die. What is the most scary part about that? What drives that fear, that helplessness, that hopeless, that empathy, all of those emotions that you all just shared? And then once you identify that fear or anxiety or whatever the strongest emotion is for you, what might you do differently if you were not so afraid? And I want us to think about that. What might we do differently if we didn't have these emotions clinically with the patient? What might be different? And I think this is especially important because when it comes to suicide treatment, there is an inherent dilemma and conflict. That I think is not present, although can be in other presentations, but for me at least, it's not as intense. And the dilemma and conflict really is that we know clinical treatment is most successful, right? If we think of common factors, when both the client and the therapist's treatment goals are aligned, meaning we are working on the same goal. This is often inherently not true when it comes to suicide treatment. And here is the reason. The therapist's goal is to prevent suicide. Right? That is certainly often my goal. And I believe that suicide is preventable. However, the client's goal is to eliminate pain and suffering via suicidal behavior. So we can see right here, here's the conflict, right? We have two different treatment goals. And what I believe we have to do, and what I'm going to show you how to do today, is we have to change the goal. If our sole goal is to prevent suicide and the client's goal is to eliminate pain and suffering, we are never going to get on the same page. So instead, we need to change the goal and set a goal to decrease suffering with our clients. We actually need to focus on improving life, not preventing death. And I think it's really important that ambivalence is always present. If someone's talking to you and they are still alive, they are ambivalent about wanting to die. So we can always count on that and lean into that inner conflict. But I don't try and prevent death. In my mind, it's not my primary goal anymore. It is actually to improve life. And my hope is that by doing so, I may prevent death or help the client too, because ultimately I have no power, right? But I may, if I can decrease suffering with my patients, then maybe they will choose to prevent death or find a different way. Today's presentation is really going to be a deep dive into chronic suicidality which really is a persistent wish to die. So we're going to describe that. We're going to distinguish that between acute suicidality and talk about the differences in assessment, treatment planning, and crisis response planning with individuals who are experiencing that persistent suicidal intensity. Joel Paris describes chronic suicidality as when life becomes so painful that people are half in love with death. It's described as chronically thinking about suicide, threats to end life, and making multiple suicide attempts. Chronic suicidality often also includes a broader range of self-destructive behaviors, including substance use, non-suicidal self-injury, risk-taking, aggression, sexual acting out. And often what I've found is that as suicidal intensity decreases, other self-destructive behaviors may increase. So that is something to pay attention to. Methods generally recommended for the management of an acute suicidal crisis can often be ineffective and counterproductive for chronically suicidal patients. And we'll explain why, but the suicidal thoughts are not always an emergency. They become the person's baseline in essence. There's no uniform definition of chronic suicidality that I could find. If someone has one, let me know. In the literature, the authors often just state chronically suicidal without a definition. I think it's something that those of us who work in this field know, sense, and can perceive when working with clients experiencing this level of suicidal distress, but it's hard to describe. So here's some examples of some definitions that I found. But because of this lack of uniform, I actually asked my patients. Most of my patients that I work with experience chronic suicidality, so I asked them, and here's a few of their responses. An affliction where an individual is unable to see a viable future, has a deep feeling of knowing that everyone, all people, would be happier if they were just gone, and internalizes a personal realization that their problems are impossible to solve. It is a deep held belief, a knowing about the self that defies all logical and rational evidence to the contrary. Important thing to note about chronic suicidality is that it often persists despite improvements in overall well-being. And I have certainly found this to be true, and that is what the research shows. Dialectical behavior therapy in CAMS, we have many great evidence-based treatments that do an excellent job of decreasing suicidal attempts. But the suicidal wish often persists. That ideation that continues is often still present, even as the person's life improves or they have a decrease in self-destructive behaviors. The other thing that's really important is the wish to not exist and the suicidal fantasies often begin in childhood. Again, there's limited research on this, but from my own clients who experience a persistent wish to die, most of them began having their first suicidal thoughts pre-adolescence, certainly a lot more in adolescence. When I worked with adolescents and children, many of them had suicidal thoughts that began around age 7 or 8. And that's what I've found most consistently. One way to think about this persistent or chronic suicidality is that we need to distinguish it from acute suicidality. And I can't say his name, but Kokiak describes it like this. Acute suicidality is a time-limited crisis like pneumonia. Chronic suicidality endures like diabetes. He further says that the patient must take ultimate responsibility for managing the illness. Like irresponsible management of one's diabetes, the irresponsible management of chronic suicidality may have a fatal result. However, neither taking over the patient's life nor attempts at rescue are likely to succeed. The tricky part here is that individuals who have a persistent suicidal wish also experience acute suicidal crises. And it's our job to differentiate, or as we'll be learning, to teach the patient to understand the difference, to be able to recognize, is this my baseline? How is my suicidal intensity, or is this an acute suicidal crisis that requires more intensive intervention? Suicidality and diagnosis. It's important to recognize that suicidal behaviors are transdiagnostic, meaning they cross across all diagnoses, whether it's psychiatric or medical diagnoses, and they can present without a diagnosis. Chronic suicidality is the same. It presents with or without a diagnosis, and chronic suicidality behaves like any other chronic condition. Also really important, research consistently shows that suicide-focused treatments reduce suicidal thinking 50% more than treatment as usual for a presenting DSM-5 diagnosis. What that really means is if you're working with a patient with major depressive disorder, recurrent severe, and who is also experiencing suicidal intensity over many years, if you just treat the depression, it is likely that the suicidal thoughts and behaviors will persist. And I have seen this over and over. Individuals began to have relief from acute psychiatric disorders like substance use, depression, psychosis, anorexia, and the suicidal wish continues. It is often the last thing to go if it ever does. In fact, my goal clinically is often to have the suicidal wish manageable or decrease, not disappear, because that's often unattainable. There are many great theories and models that help us to understand suicide. The one that I use the most to explain this, and I pull this up with patients actually and walk it through with them often, is the ideation to action framework, or the three-step theory by Drs. Klonsky and May. What their research shows is that pain plus hopelessness creates suicidal ideation. And this makes some sense, right? And the pain can be psychological or physical pain. So the most severe pain I've ever been in my life was when I had a kidney stone, right? The pain was so intense, I wanted to die. But I was not hopeless because I knew I could go to the ER, I knew it was temporary, and I knew it would pass. So I did not experience suicidal ideation. My uncle has cluster headaches. And if anyone knows what cluster headaches are, they are chronic, they're extremely debilitating, and there is no effective treatment for them. They just get worse over time. He experiences pain to the point that he cannot function. And there's really no hope that they will get better, right? In that context, it makes sense that he may experience suicidal ideations. And I think we can all relate to this, right? Whenever we are in severe pain, we want to escape in some way. We want to get out of that pain. And sometimes thinking about leaving this world or our bodies may make sense. What moves things to a suicide attempt is the idea of low connectedness to life and capability. And low connectedness to life really is a lack of purpose, social connections, feeling a burden to others, as Thomas Joyner would say, thwarted belongingness, or just feeling like the world would be better off without me, right? And for individuals with chronic suicidality, that low connectedness to life seems to be present because of this deep held belief. Capability really is both access to lethal means, but also dispositional and genetic factors that may increase the likelihood that someone has the capacity to end their own life. When all these things come together, that is often when we see suicide attempts. And when we think about this, this gives us a great roadmap for intervention and treatment planning of where we need to can intervene with clients to decrease that capability or increase connectedness to life. Often the way I think about it when I'm conceptualizing clients is, does their pain exceed their connectedness? And if the answer is yes, then we have some work to do. Another way to think about suicidal behaviors is this idea of the suicidal belief system, which comes from cognitive behavioral theories of suicide. It is really characterized by a pervasive hopelessness. And there are three main pillars: a sense of unlovability, a sense of helplessness, and poor distress tolerance, that I really can't stand this pain anymore. Again, knowing this belief system gives us our treatment plan of where we can intervene. And I think too, when we think about the paradox in the suicidal mode, right, or within the system, is that often the only way for individuals to go on living is to maintain the option of dying. It's an interesting thing to think about, that people threaten to die in order to stay alive, and that the suicidal wish has often become the primary coping strategy for the psychological and emotional pain. And while this may sound counterintuitive for anyone who has not experienced suicidal thoughts, I imagine we all have escape fantasies. When my life or work gets really overwhelming, I know I can go and disappear and sell necklaces on a beach in Mexico, right? I think most people have this idea of, I could just run away, I could escape, right? And that's a way to navigate the knowing that we have an exit, or that we could quit, that we could do something else, helps us tolerate what we have to do, or the things about life that may be hard or unpleasant. And in many ways, the suicidal wish is the same. One thing that's important to note is that the chronic suicidal wish often becomes egosyntonic, meaning it feels right and natural to the person to not deserve or desire to live. It becomes a part of their personality structure. Oftentimes, clinicians make the mistake to compare these chronic suicidal states to depression. However, it's often much more profound. Depression is often a sense of loss or even grief because the individual experiencing a major depressive disorder can remember not being depressed. However, to individuals with persistent suicidality, the suicidal state has always been there, and there is often no loss for them because it's the way they perceive they always have and should be. When early on in treatment, clients will often say things like, I feel like I'm betraying myself. I shouldn't be alive, as they start to feel better or experience more hope. And I think that this really is important for us to remember. This can also be quite frustrating for clinicians. The intensity of these feelings to a person with suicidal thoughts can often be seen as attention seeking. So when we hear about someone who's constantly suicidal, right, or cycling in and out of emergency rooms or crisis centers, I would hear things all the time in the hospital like, oh, they're just attention seeking. I really disagree with that assessment, although it certainly can feel that way. I believe that these individuals simply require more attention and lack the social skills and ego strength to ask for what they need in a more pro-social way. One of the most important things that we can do in the face of this level of suicidal despair is to empathize with the suicidal wish. We all know the benefits of empathy. I saw in chat that some of you put that when you are faced with a suicidal person, that empathy comes up. We all know this. It helps us connect with clients and build a therapeutic alliance. However, what I have found is that when it comes to a suicidal crisis, clinicians often miss the mark. We focus on preventing death instead of the cause of the distress and pain. And this makes sense because the stakes are so high. Both the patient and the therapist feel scared, angry, worried, vulnerable. So we often change our approach and move away from compassion, understanding, and empathy and into action, assessment, and defensive practice. Like I described, this creates a conflict between patient autonomy and a struggle for clinician power and control. What the research has really shown is that when we can engage with empathizing with the suicidal wish, we can be much more effective. In fact, a conference of suicidologists did a large research study where they asked attempt survivors what would have helped. And here is what they overwhelmingly said. We could have only talked to a person in that suicidal crisis who we knew would not be afraid of listening without judging. In a suicidal crisis, we never could have trusted a person who would want to talk us out of it. Then our first instinct is to talk the client out of their suicidal wish. Being empathetic with the suicidal wish means assuming the suicidal person's perspective and seeing how this person has reached a dead end without trying to interfere, stop, or correct the suicidal wishes. This means that we attempt to empathize with the patient's pain experience to such a point that we can see why suicide is the only alternative available to the patient instead of working against the suicidal strain. The shared experience when the patient narrates and the clinician listens, and both of us learn their story and understand their pain, is instrumental in reestablishing the patient's broken sense of self. It allows the therapist, along with the patient, to grasp how suicide came to be seen as the only solution. Only then can the therapeutic process begin. What we're really doing, the benefits when we can do this well, is we teach clients to tolerate their pain. Once we can tolerate a client's pain, we're actually communicating to them they can tolerate their pain. And I think this is really important. If we move too quickly to defensive practices or safety planning, we're actually demonstrating to clients that that action is more important than process. And in the face of a suicidal crisis, what I want is much less action and more slowing down. It increases the client's exploration of themselves and creates more meaning. And it supports the client's active self-healing. What it really does is that when the story is retold to an empathetic listener, the client actually opens up and has a prospect of an alternative solution. Our goal is to be able to contain and bear another person's death wish without being overwhelmed and incapacitated by anxiety. This is hard to do and requires a lot of patience and practice, I would say. And often when I teach at a university and I have my students just role play, just empathy over and over again, I think it really requires that level of work to be able to sit and not move into problem solving, which is our first instinct. But when we can do this, I'm always surprised when I can actually sit and listen and empathize with a patient. They actually come to me and start to say, oh, well, maybe not. Here's some ways, right? And they actually feel better. It's an interesting process as they share all the reasons why they want to die and why it makes sense to die. They actually start to feel better. And that's when their perspective can change from a death orientation to a life orientation. It's really quite powerful. And I think it's really important to not work against the suicidal stream. Clinicians often feel that if we empathize with the suicidal wish, then we're communicating acceptance of suicidal behavior. However, the opposite happens, right? As the patient understands their own pain experience and feels understood, the pain begins to lessen. Until we can empathize, I truly believe that we are locked into a life and death struggle with our patients that clinicians ultimately have no control over. We want to take a stance that the most empathetic position really is that although we disagree that suicide is necessary, we understand that for the present, it needs to be retained as an option, right? So when I'm working with a client, suicide is never off the table because I don't have any power over that, right? But we really are focused on what else is on the table. So my goal is to add more things on, not take off, if that makes sense.
Good night, Junior.
Yeah, I want to
Hey,
pause
girl.
real quick because we've talked about a lot about empathy and see if anyone has
Girl,
any
that's what she
questions,
said, girl.
insight, or comments.
And be careful, Junior. That she said it
And
was
if someone's, I know it sounds like someone's,
girl. And they was supposed to deliver that damn thing Wednesday.
Anna.
Kiosha?
Yes, I thought so. Thank you,
You
Michelle.
got it.
Just a reminder to please mute. Thank you.
You're welcome.
Um, I want to just pause quick. I've talked a lot and I want to pause. I've covered a lot of content to see if there's any questions or comments. Feel free to put them in chat. Okay. I'm not seeing any, so we will continue on. But please feel free to put into chat. When I get to this point in trainings, I often, clinicians will often say things like, well, we can't just sit in empathy the whole time. We have to do something, right? Um, and yes, we do. And so thinking of the zero suicide, framework, right? We then have to intervene. And to me, empathy is one of the greatest clinical skills that we can offer. So I do see empathizing with the suicidal wish as a clinical intervention and probably one of the most important ones. But we know from zero suicide the importance of we actually do have to assess and we have to safety plan and we have to provide suicide-focused treatments. So yes, as much as I would love to just sit in empathy and let my clients share in some sessions, it truly is just empathy. We also need to assess. So once we've empathized and we've begun to establish a therapeutic rapport, then we do need to move into a suicide risk assessment. And depending on where you work, that may look differently. You may be using the Columbia or some other suicide risk assessment tool. It is important to use an evidence-based suicide risk assessment and to be consistent with that. Every client that we see should be assessed for suicide. However, I think we can do a better job of implementing suicide risk assessments. Stacy Friedenthal states, just look at the standard risk assessment interview. It can seem like an interrogation because it's just question after question we're asking for our own benefit. I have yet to hear a patient say, I knew when I woke up this morning, I'd feel much better when asked 15 yes or no questions about my suicidal thoughts. Those questions are for us. A patient who is struggling with suicidal thoughts has very different needs from ours. Sometimes a patient will tell me, I need help staying safe. But usually they say things like, I need to feel better. I need to stop hurting. So while suicide risk assessments are extremely important, and I encourage the use of them always, I think we can do a better job than a checklist approach. If we're just going down a checklist or just using a self-report measure and not following up with that, we will miss the connection with the patient or understanding their suicidal experience. A one-size-fits-all approach serves to distance and marginalize suicidal patients and contributes to the lack of effectiveness of mental health professionals. So I really think it is about adapting and using suicidal risk assessments better. And I'll share some ideas. It's really important to note what suicide risk assessment is not. Suicide risk assessments are not predictive, meaning there's little evidence that suicidal ideation is at all helpful in predicting suicide attempts. So even if we're using the Columbia or CAMS, and we're putting people into high risk, moderate risk, or low risk categories, they actually don't bear out into who will or will not attempt suicide or die by suicide. What it does communicate to us is it does help us understand that person and what resources they need. So even though it's not predictive in who may or may not attempt or die by suicide, it does give us really valuable information. Suicide risk assessments also are not protective for clinicians. Now, not doing a suicide risk assessment does increase our liability as clinicians, but if someone scores at low risk, it's not at all protective if that person does die by suicide. What is protective, I'll talk about in our skills session about how to protect ourselves. And what does actually help. It actually is more about the treatment alliance and engaging in suicide-focused behaviors. And in most cases, suicide risk assessments, when they're completed as treatment as usual, are not helpful for clients, nor are they therapeutic. And I think that that is important information. Suicide risk assessments can be, they are a requirement. They're an ethical requirement, an organizational requirement, and certainly many accrediting bodies require them. They really do help us identify strengths and protective factors that the person may have. They become the tool for crisis safety planning and treatment intervention. And that to me is the most important piece. If they're done well, meaning they're more collaborative and narrative approaches, it can enhance the therapeutic alliance. They can really help the patient understand themselves. And I like to think of a risk assessment as an empathetically grounded conversation. In my mind, the goals of a suicide risk assessment, in the past, I was taught they are to determine who will or will not be at risk of suicide, right? But like I shared, the research doesn't support that at all. So I've changed my goals. Here's my goals of a suicide risk assessment. It's to understand the person's individual suicidal belief system. It's to help me build a therapeutic alliance, to demonstrate safety for the patient within the relationship, our relationship. That really means that they can be open and I can tolerate their suicidal wish. They can be honest about their past suicidal behaviors, and I will not react from fear-based or overreaction. And it really aids me in crisis safety planning. And most importantly, it helps me identify my treatment goals and interventions that the person will need to improve their life. And I think no matter what suicide risk assessment you're using, whether it's the Columbia or any of the other various ones, Columbia is probably the most commonly used. We want to start with a narrative assessment. If you do this, even before jumping into the Columbia, it will help guide your treatment. So I just ask the client, tell me their story of the suicide attempt that impacted them the most if they've had multiple attempts. The most recent, the most potentially lethal, the time when they had the most intense suicidal thoughts, right? I just asked them to share with me when things were at the most dire. And then I allow the narrative to continue while empathizing and not moving into crisis or problem-solving mode. This is where I gather the most information. I become really curious about their suicidal ideation, their frequency, triggers, intensity, duration, and ease of elimination. The Columbia Suicide Rating Scale, if you're familiar with it, does a good job of addressing all of these. But I think it's all in our approach if we take a more narrative approach with the Columbia versus just a yes or no scaling question. So I think we can just deepen our understanding. What my goal really is I want to develop an individualized case conceptualization with my patients. I want to understand what about their history facilitates their suicidal behavior. What triggers their suicidal crises, right? That is different for every person. For some clients, it is pain. It may be hormonal shifts. Suicidal crises are often triggered in the context of interpersonal problems, right? And I really want to understand how the patient thinks about suicide. One of my favorite questions to ask during suicide risk assessment is, when you have suicidal thoughts, do they comfort you or frighten you? And that's really important, because the suicidal thoughts, for especially people with chronic suicidality, are actually really comforting. It's a way, it decreases pain to think about dying. And sometimes it can be very distressing, right? And I want to understand that difference and what types of suicidal thoughts are comforting versus distressing. I want to know what the patient feels during a suicidal crisis and what type of arousal symptoms the patient is experiencing. That may be lack of sleep, right? What types of thoughts? Are they having any physical sensations? And then I really want to understand what suicidal behaviors have been demonstrated and planned. So really thinking about, does the person have a means identified or a method identified, and any future planning. This becomes really important because often in my work with patients with chronic suicidal thoughts, I'll never forget, I had a patient who started intensive outpatient therapy, and she came to the IOP group and said, well, I turn 21 in 6 weeks, and gave me her birth date and said, I've wanted to die since I was 8 years old, and I'm giving this thing a shot. If it doesn't work, I'll be dead before I turn 21. Immediate fear, right? Here's a very capable person. I just met them, and they are telling me they're going to be dead if I can't somehow magically help them, which seems overwhelming and quite impossible, honestly. So thinking about that pressure, right? So much pressure. After the flood of anxiety and panic, I realized what she had said. She said, if this doesn't work, I will be dead, right? So thinking about what that means, there is an element of hope there, and there is an element of time. She is giving herself time. So my response was, okay, we've got some time. Welcome to group. And I think that when we can slow down and really focus on what the person is saying to us, right? The end result may be the most lethal and the most frightening, but right now they're saying we have time. And that becomes really important. One of the most important skills that I have learned, especially working with individuals with chronic suicidality, is to teach patients to rate their own risk. And I picked this picture because this, I believe that's an orangutan, looks so proud. And I think that when we can teach patients to rate their own risk, meaning when they start to understand how to say, my suicidal intensity is at a 10 versus a 5 versus a 4, they actually have a greater sense of autonomy and begin to feel more in control over both their emotions and their suicidal thoughts. And when we get to the skills session, I'll talk more about how to do this and how to help patients do this, but it's really quite effective. both for clinical treatment and for the client. Okay. We're, as usual, I'm running out of time, so we're going to skip over a few things, including this one. Actually, no, I'm going to show this. This is Marcia Linehan talking about working with highly suicidal individuals.
The one thing I've learned about treating highly suicidal people is that if you try to control them, things get worse instead of better. And your first desire is to control them. And I have definitely done it in the past with clients. The treatment I've developed, which is the one that I apply, which is dialectical behavior therapy, all therapists have to be on a treatment team. And the function of the team is to treat the therapist. I call my colleagues, I talk about it in team. If somebody's really high risk, I can call another therapist and review my treatment plan and say, okay, does this make sense? This is what I'm doing. Do you see any problems with my plan? It's very helpful to have a team. On the other hand, if you're going to treat suicidal people, you have to know at the onset, it's a risky business. As I say to my grad students all the time, I say, look, you're either treating the patient or you're treating yourself. And if you're treating yourself, you should get out of the business.
It's in the typical Marcia Linehan direct way. But I think what she's really talking about here is the difficulties and the challenges in working with chronically suicidal or all suicidal individuals. Marcia Linehan describes what it is like to work with suicidal individuals by telling a story. The suicidal individual is trapped in a small, dark room with no windows and high walls. The room is excruciatingly painful. The person searches for a door out to a life worth living, but alas, cannot find it. Scratching and clawing on the walls does no good. Screaming and banging brings no help. Falling to the floor and trying to shut down and feel nothing gives no relief. Praying to God and all the saints one knows brings no salvation. The only door out the individual can find is the door to death. The task of the therapist in this situation is to somehow find a way to get into the room with the patient, so to speak, and then together search again for that door to life that the therapist knows must be there. As you can imagine, or may have experienced, climbing into that painful room is taxing on clinicians. In addition, specifically when working with individuals with chronic suicidal behaviors, we stay in that room with our patients for quite a while sometimes. From my experience, when clients do find a way out through therapy or their own social supports, we often go back in together. When a new psychosocial stressor emerges, this is extremely painful for our patients when they recognize that the mania, hopelessness, psychosis, suicidal thoughts, etc., return or are intensified. It is also painful for us. We have to somehow tolerate that the client may choose the exit door to death when they leave the hospital, our offices, our groups. The clinical skill required to do this is to learn to tolerate the risk. We need to manage our own emotions in order to not have them adversely impact the therapeutic alliance or our conceptualization of the client. We also have to find a way at the end of our workday to climb out of that dark room, even when our patients are sometimes still stuck, and return to life, engage with our family and support systems, and find joy in our life worth living. I want to share with you all some skills that I have learned to be able to stay in that room and to climb back out to life at will. And just to clarify, this is a work in progress, I think, for everyone, including me. Joel Paris describes doing therapy with chronically suicidal patients as working on a knife's edge. And this is often how it feels. When I think of the hazards of doing this work and what I must navigate to both protect myself and my client when we are in that painful room. Because I'm working on the knife's edge, I need to put on armor or have internal strategies that protect me from being wounded. This is an ongoing challenge, and I'm still working on it. But it's important. I've had patients in crisis, and due to my inability to tolerate the risk or desire to move the conversation along because I had a lot of paperwork to do or didn't want to sit in that sadness today, I push too quickly to solutions and safety planning. That's when my patients tell me, "You are not helping, Anna. I just need someone to listen, not solve my problems." And I remember that often. Here's the skills that I find to be the most helpful in tolerating the risk. One is it requires a tremendous amount of patience. We have to be patient that this process, when we think of chronic suicidality as a chronic condition, just like we're patient with diabetes or with addiction, we have to be patient with suicidality. We have to always maintain hope and belief. I have to firmly believe that suicide is preventable and that people can get better. I also have to be really comfortable with partial results. As I said, my goal, especially when working with chronically suicidal individuals, is never to not have them be suicidal. It's to have them be able to manage their suicidal thoughts, right? Because that having no suicidal thoughts after 30 years of having suicidal thoughts may be unrealistic. So what partial results and really winning those? I don't believe we can do this work without consultation and support for us. We have to be openly talking to colleagues, supporting, and I certainly use consultation constantly. We also have to recognize that not tolerating the risk may result in negative outcomes. So there's a real risk if we can't learn to do this. I think we really have to tolerate and embrace the anger and the pain. And be okay in the ambivalence, in the unknown, and recognize that we don't have power. When I first started working with addiction in addiction treatment, where I think similarly, if you work in addiction, you have to learn to tolerate the risk with the multiple, with the chronic condition of relapses. Dr. David Mealy spoke at a presentation I was at, and he said we would never fire a diabetic patient for having high blood sugar. Why do we fire patients for having symptoms of their psychiatric illnesses? He was talking about substance relapse specifically, but I think the same applies to symptoms of borderline personality disorder, anxiety, depression, and certainly suicidality. And I think this is when we just be. We have to learn to be with the patient and to recognize that we're walking along on their journey. And ultimately, what makes me tolerate the risk is hope. hope that and belief that individuals are capable of saving themselves, and that the work that I do with clients has the potential to help them save their own life. If my anxiety is too overwhelming, there is something off balance with me. I have lost hope and I need to reset my expectations. When we think of working with chronically suicidal individuals, there are some implications for clinical practice. One is the use of interdisciplinary teams. That becomes really important. Using our supports, talking to psychiatric providers or medical providers. Often longer-term treatment is likely, including intermittent treatment. And what I mean by that is it is not uncommon for, in my work, in outpatient treatment with clients, to have them step up, maybe even to the hospital for a minute or to intensive outpatient and then return, or to feel better, decrease sessions to once a month or terminate treatment successfully and have them return 6 months later when another suicidal crisis increases. We also may need to increase the intensity of treatment. And intensive follow-up often becomes needed. So having case management, telephone contacts in between sessions as appropriate, and as your comfort level with that. That can be really helpful for individuals with a persistent suicidal wish. And at times extend boundaries. This needs to be really carefully thought out and make sure that it's clinically appropriate, because at times maintaining firm boundaries can be the most self-efficacious thing to do for clients. We also really have to be willing to dig into pain and trauma. There's often a fear with clinicians, including myself at times, of not wanting to do intensive trauma treatment when someone has a persistent wish to die. My worry is if we dig into this trauma, right, and start doing cognitive processing therapy or more intensive trauma-focused treatments, that may increase the suicidal thoughts. But when we think about if my goal is to improve life and decrease suffering, not prevent death, then I am clinically responsible to do everything I can to improve their life, even if that is digging into some really painful trauma. Question, what's an example of trauma treatment? EMDR, trauma-focused cognitive behavioral therapy, psychodynamic treatments, so many trauma treatments. Cognitive processing therapy is one that I use, or art. So there's a lot of different ones. And on the handout, I can include some that are evidence-based. One thing that I found to be very helpful, especially with chronic suicidality, but really any suicidality that's persists beyond just one-time crisis, is to teach patients to observe their suicidal thoughts with curiosity and detachment. So it really is externalizing. So becoming mindfully curious about it. Oh, I'm having the thought of wanting to die. And, becoming acceptance and commitment therapy, although not an evidence-based treatment for suicide, can be helpful in that way. And recognize that the option of suicide might be what helps your patient to stay alive. We want to do anything as a clinician that facilitates attachment, connectedness, and alliance. Sometimes that can look like emergency availability, promptness in returning phone calls, but we also need to make sure that we are not creating dependency or reinforcing the patient's belief of helplessness. We should never be the first call on a safety plan, even in a suicidal crisis. I think really I've kind of talked about all of this, but really in every session, this is kind of the model I follow in every session when I'm working with someone who experiences chronic suicidality. I'm assessing this and talking about this and skill building, and even if it's just a small part of every session. If we're working with a person who has suicidal thoughts or behaviors, we must have a suicide-specific treatment plan. The Therapeutic Alliance is often the endpoint in treatment, but and this is really important when we think about the suicide-focused treatments. We need to have a specific treatment goal and plan specifically targeting suicidal thoughts and behaviors. Once we've assessed and we've engaged in treatment, we also need to have established a good safety plan with clients. Safety planning probably is one of the best suicide prevention tools that we have. And it really helps the client make decisions during an acute distress and impaired problem solving. And in the next session this afternoon, I'll go into more detail about safety planning specifics. But I think for individuals with suicidal thoughts, chronic suicidal thoughts, safety planning becomes much more complicated in my mind, because often the suicidal is on the safety plan. Even if it's not written, dying by suicide is always on that person's mind. So when I think of safety planning, my goal really is to have this be a very collaborative process and to not control. I start early and update constantly. This is never a one and done. This is something that we're addressing every session, updating, finding out what works for them. Harm reduction can be really helpful when it comes to chronic suicidal behaviors, but really what helps them, what distracts them. The other thing that becomes really important is we need to have alternative supports to connection. When we think about that disconnection, one of my biggest goals is to increase connectedness to life on the safety plan. And for people with chronic suicidal behaviors who have often distanced themselves or they feel so disconnected and like such a burden that they're unwilling to reach out to others, I'm often putting alternatives to human relational connection. That might be pets. I actually believe that pets probably save more lives than humans. Pets, hobbies, nature, distractions, social interactions without a relationship. I had a patient who would go to the grocery store and walk around to increase her connectedness. She wouldn't necessarily talk to anyone, but just being around, or go to the library. And peer support can be hugely beneficial. There are some amazing support groups for individuals with lived experience that are non-clinical, just like your AA groups for substance use. So I definitely encourage that. But I do think we have to be a little creative and remember that the purpose of a safety plan is both to have alternatives to making a suicide attempt, but also it's a reasonable alternative to hospitalization, which is often my goal. We also really need to talk about means restriction, which means restriction is the #1 most proven suicide prevention tool that we have. Most individuals with chronic suicidal thoughts have multiple plans and means laid out. it's important to ask about many different methods and ideas. When I'm conducting a suicide risk assessment and I say, what have you, what way have you thought about ending your life? And they might say overdose. My first question or my next question is, what else have you thought of? Because often there are multiple methods. And we can get creative in collaboration with the patient. And I think sometimes this can be really tricky. I'll share an example. I was working with a patient who had been diagnosed with post-traumatic stress disorder and borderline personality disorder. She was a retired from the active duty military and had chronic suicidality. She had multiple plans and means disclosed. So we engaged in lots of means restriction, including 1 week prescription refills, giving knives to neighbors at times. However, this person being a veteran had a firearm in their home. And the firearm really helped calm their PTSD symptoms. And the patient was adamant about never using that firearm for fear of the damage the family finding would cause. So my goal is not to control. I did not remove, not that I had any power to, but I accepted the patient and said, okay, let me know if it changes. But for now, that firearm, because it was so important to their PTSD symptoms, remained in the home. However, following a suicide attempt where she was hospitalized, she disclosed having thoughts of using the firearm due to all other methods being unsuccessful. And I was really grateful that she told me about that. And my first instinct was to get the firearm out of the house. However, the anxiety of not having that firearm in the home, she lived alone, was unbearable. So together, we made a card that she could tape on her handgun that reminded her of why she wanted to live. So it was in essence a kind of fire, a gun lock in a way that she would have to rip off. And she could tape that all around her handgun and would have to take that step to look at that and slow it down. So that was our creative lethal means restriction. Not ideal, right? Ideally, that firearm would have been temporarily removed, but it's important to recognize that this must be a collaborative process. We need to involve the patient on what they think will work best, and if possible, involve family and supports. Involving collateral contacts and client support systems becomes really important. I think if we can do this during assessment and certainly in safety planning, it becomes really important, both for us and for the patients. If you're working somewhere and you have emergency contacts, which most agencies do, it's really important to think about, do you require emergency contacts or are they optional? And to really be clear with patients about when the emergency contact will be notified. I always communicate before notifying an emergency contact. If for some reason my client doesn't show for a session, I will be very clear about the steps I will take before contacting emergency contact. And recognizing that if we contact emergency contacts or do a welfare check, that there may be a possible therapeutic rift and repair process following that. I think when it comes to obtaining consent, I think this becomes important throughout treatment. Our goal in working with individuals with chronic suicidality is to increase their autonomy and sense of control in many ways, and to establish that working alliance and trust. So I want to get ongoing consent before every step, before every suicide risk assessment, certainly before contacting any support systems. That just becomes really important. Also important, HIPAA allows for communication between professionals, only professionals, even without a release, to assess acute suicide risk. We always want to seek consent if possible, but it's important to educate other professionals about HIPAA. This is really important for transitions in care. So if our patient is admitted to the hospital, we can communicate even without consent their suicide risk, only suicide risks, right? So not diagnoses, not their psychosocial history. But if we have concerns about suicide risk, we can communicate that to another care professional, which is really important in thinking about the zero suicide framework of collaborative care and educating and intervention. I want to talk briefly, and we'll talk more about the hospital environment in the afternoon session. But for the chronically suicidal patient, the hospital environment can be toxic. There's often a secondary gain from hospitalization. Malignant regression may occur, which really means that the patient actually gets worse in the hospital instead of better. And hospitalization may reinforce to the person that hope, like that there is no hope, right? So thinking about, which makes sense, right? My pain is so intolerable that I have to be hospitalized and all my freedoms taken away, right? So in my mind, I want to do everything I can to prevent hospitalization, except for in a few key parts. Here is when I hospitalize, specific for chronically suicidal individuals. Hospitalized due to secondary symptoms. So if they are in psychosis, if there's an acute exacerbation of a psychiatric condition, mania, depressive symptoms that create a loss of functioning, needing detox, if they are having medication side effects or health problems, hospitalization may be necessary. If they are in an acute suicidal crisis, unless I can safety plan, my goal is always to safety plan first. At times, we may need to manage the patient's request to go inpatient. Many times patients feel safe in the hospital. It becomes a way to cope. Important to remember that hospitalizing is not a life, right? And our goal is to improve life and decrease suffering, which happens outside of the hospital. And if we've exhausted all alternatives to hospitalization, meaning I'm unable to safety plan appropriately. And at times I have hospitalized because I have been unable to tolerate the risk. And that is something I acknowledge, but I'm not proud of, I would say. But sometimes there just seems to be no choice. And that is okay. I think a huge piece of this work is our own self-compassion. We will talk about documentation in our skills session if you all want. But as we're coming on the end, I think it's really important to recognize the challenges of this work. The exact figure is unknown, but around 1 in 5 or up to 40% of mental health therapists and 51 to 82% of psychiatrists will experience at least one patient death by suicide in their careers. My own experience of losing a patient to suicide and the nights of staying up worrying and shaming myself at times. Did I make the right call? to not involuntarily hospitalize? Should I have done more? And I think in the face of these challenges, when our clients continue to struggle, just like we encourage our patients to speak openly, we have to allow ourselves that same grace and compassion. We need to be understanding of each other and consult, support, and not judge. Some of my patients have lost the battle to suicide, but many more have learned to fight, live, and love both others and themselves again. And I really think every day I'm just honored to be along their journey of healing and recovery, and honored to be with all of you. I want to leave you with my favorite video. It's a spoken word. If we have time, Lisa, for a quick spoken word, it's about 3 minutes. Because it gives me hope, and I often need it. So here you all go, and then I will, after that, we'll end, and then I'll hopefully see you at 11:30.
I know that you don't want to taste another day, that everything feels cold, grey, decayed. I know that loneliness has moved in and made a home in your heart, that you feel apart, in parts, apart from others, isolated, separate, defected, diseased, defined by dysfunction and constantly teased by the idea that death will appease your pain. But stay another day. I know that you feel broken, as if the parts will never form back together to make a solid, well-formed and functioning heart. But stay another day. Believe that tomorrow possesses the capacity to differ from yesterday. I know that your pain is real, and if I could hold it in my hands, I would feel its weight, shape and form and the heaviness of your despair. But stay another day. I know that depression blinds you, masking, obscuring reality, showing you only what is broken, the shattered glass, sharp pieces, the torn edges, what is dark. Revealing to you only a singular dimension of what it means to be alive, distracting and depriving you from all the reasons that motivate you to survive. Depression blinds and blurs your vision with precision, numbing you to sleep, preventing you from envisioning the future you wish to keep, demanding you accept defeat. But there are so many reasons to stay. Stay another day. Choose to live, choose to fight, choose to stay. Know that what is broken can be mended and sewed back together, repaired, revived, repatched, renewed, restored into something splendid. That the breath in your lungs, the sun on your skin, and the people you love are reason enough to stay. That love drowns out the darkness, silencing the voice of defeat. Conquering deceit, cutting through the misery, it is love that makes us complete. So stay another day, open your eyes and refuse to be blind to the beauty that persists despite the brokenness. Touch, taste, smell and see another day. Because love, joy and hope exist. Please stay another day.
Thank you all so much, and I hope to see you in just under 30 minutes. And yes, I will include the resources, and this is being recorded. So anything else, Lisa?
The only thing is, I see a lot of people are asking, is this recorded and if it's going to be available? We are recording. Christina, are we going to have this available on YouTube or on our website?
It'll be on our website.
Okay, that's what I thought, but I wasn't sure, and I thought, oh, let me check with my tech pro.
Okay. Well, please come back, and I look forward to conversing with all of you and answering your questions, and we can dive into more content. So
Anna, I just want to say real quick, I've been in the mental health suicidal field over 30 years. Okay, so I'm telling my age now. I just want to say This has been absolutely the best training I have ever been in. You are absolutely fantastic. I knew I was excited about this, but I'm not even kidding. This is just the best training I've ever been in. You are fantastic.
Well, Lisa, thank you.
Oh, you're welcome. Thank you. Thank you so much. And so I guess we'll meet back at 11:30. Is that our plan, correct?
Yep, I'll be here about 5 minutes before that just to reset everything and see where we're at. And yeah,
All right. Great.
thank you.
Thank you.
I'm a little early, so people. Like some people are saying they're back and ready. Thank you. Is it getting warm in Tennessee now, Lisa?
It's warm to everybody else, but until it gets 100 degrees, Anna, I am cold. I'm sitting here with a little heater on 77 on my.
I'm the same way. No, I moved to I live in Salt Lake City, Utah now, but I moved from Florida. And so I just miss the Florida humid summer.
Oh,
Uh,
that's how I am. When I go to Florida, I love it. And my family, they're like, oh, it's hot, it's hot. But we spend the whole time, Anna and I was talking about it the other day, and I'm like, we are beach people. We stay on the beach the whole time. Well, my husband, he stays on the little, we get a condo and he stays on the little, oh, what is the thing? Not a deck, the balcony thing.
yeah.
Go on the beach for a while, but he's from like outside of Chicago. Been here over 20 years, but he's still a Chicago boy. He likes the snow and stuff. But
Yeah.
I love the heat. I'm seriously sitting here with a heater on, and because I'm cold, I'm so
Yeah.
cold too.
Yeah.
Yeah.
No, it looks like Regina says it's quite cold in Tennessee. In Tennessee today compared to South Florida. I believe that from South Florida.
Yes. Yes.
Well, is there anything you want to say, Lisa, or should I just dive in?
Oh no, dive in.
Okay.
You're the professional. Go for it.
Ah, well, thank you all so much for coming back. You are welcome to turn on your camera at this point. I'd really love to hear from you all. I can certainly dive deeper into some things that we didn't get to cover, like documentation, or dive deeper into risk assessment and those things. But mostly for our next hour together, I really want to answer your questions and hear from you. So for this part, you are welcome to put in chat or even unmute yourself and ask a question, and we can have more of a dialogue all together. Yeah, I am open. So I'm gonna give a few minutes to see if there's any questions or requests for specific topics where you want to learn more, me to dive deeper. So feel free to put in chat or unmute and just talk, because I would love to get to know each of you and your unique experiences. Yeah, I'll just give us a few minutes.
Hey, my name's Ashley. I'm with Metro Drug Coalition. My background's actually in medical social work, so I'm really excited for this afternoon session just because I have some questions that are probably more related to that and not as
Yeah.
much with the behavioral health side. But we're working on a program working with moms with high ACE scores, so the adverse childhood experiences. And we're looking at partnering with Catholic charities. And so they help with women who are looking at maybe giving up their baby for adoption or helping women navigate if they had an abortion and it was very traumatic. And so I have a feeling we could run into this, especially like the helpless or hopelessness, and then any co-occurring diagnoses, mental health, history, anything like that, trauma. So um, I didn't know, have you ever worked with parents, I guess mother, father, grandparent, anything like that? Have you ever worked with people that have dependents that they're caring for and helping try to navigate their emotions while also still being a caregiver?
Yes. Yes, absolutely. And I think that is one of the most unique things in thinking about individuals who experience suicidal thoughts and intensity or have multiple suicide attempts, right? They exist in families, right? Thinking of my own family, with my family's history of suicide. So yeah, the caregivers who are working with individuals who experience suicidal thoughts also need a tremendous amount of support. Um, there's actually a really great new book that came out a few years ago called Loving Someone with Suicidal Thoughts, and it's by Stacy Friedenthal. I'll put it in chat. And it specifically talks to caregivers or loved ones and parents, especially, who have someone that they really care about and how to empathize with the suicidal wish as a loved one. But I do think when I worked on the inpatient unit or with adolescents, many of the adolescents had, chronic suicidal thoughts, and it was very distressing for the parents, the teachers, everyone involved in that young person's care, to navigate that and to experience that. So yeah, and we do know that there is an association between ACE scores and not only behavioral health disorders, but also suicidality does tend to be linked at times to early childhood trauma. Did that answer your question, Ashley?
Yeah, sorry, I couldn't find the mute button. Yeah, I appreciate that. And I didn't even think about teachers as well. I feel like clinicians, and maybe in like the teacher or like school nurse or something in that capacity where there's that intersectionality in providing care to somebody. but the secondhand, I guess you could call it trauma that a person could experience if they lose a client or lose a patient. And so, it's easy to forget that side of it as well. My background's in hospice care, and so that's why I was going to save a lot of my stuff for this afternoon. But talking about when we have someone that's terminally ill, and the discussion with the interdisciplinary team and how to manage their understanding of someone experiencing suicidal ideation and everything. So
Yep.
I just that interdisciplinary approach, I'm big on that. And just because there's so many people involved and there's layers and yeah, so I appreciate it.
Yeah. No, really, and I think just like if I'm working with a patient with any, you know, chronic disorder, whether it's a medical, right? So thinking of you, Ashley, in the medical social work, if you have a patient who has, maybe cancer diagnosis, right? You're really getting the entire family together and deciding, okay, how can we provide support? And I think whenever we're working with individuals with certainly psychiatric disorders like bipolar, schizophrenia, we're doing the same thing. And we should, with the client's consent, do the same thing with suicide. So if I'm working with an adolescent or even a young adult who has chronic suicidal behaviors or multiple suicide attempts, my goal is to seek that, if they're an adult, seeking their consent. If they're a minor, then it's dependent on state laws. But I'm getting the whole family together. I'm getting their support system. I'm doing not only a crisis safety plan for that individual patient, but also for the system. Because, and often with adolescents, it's actually really cool. When I worked on the inpatient unit with adolescents, I would have in our discharge planning meeting where the youth would do a crisis safety plan for at home at discharge. We would have the parents or caregivers do their own crisis safety plan. So everyone in the family had a crisis safety plan, right? So the, mom or dad can say, okay, if I'm overwhelmed because my child's putting so much pressure on me, or I'm feeling this increased anxiety, I'm scared about them hurting themselves, then here's my steps. And that became really empowering for the adolescent, right? To say, hey, we're all in this together. And really having clear guidelines for the entire system. Because it truly does take, no one can do this work alone. I also really encourage, I think every clinician or healthcare provider, we should have our own crisis safety plan as well, of how to manage our own emotional reactions and the traumas that we experience just vicariously. So I'm a big believer in ongoing, multifaceted, multi-purpose safety plans. Yeah, thank you so much for sharing, Ashley.
I have a question. Can you guys hear me?
Yes.
Okay, so this was referred for me to come to this to get information on the suicide club because I run what is called a food pantry where we handle the community and we feed them, we give them things they need. But and we've been doing this before COVID, but now everything has changed. You can see the struggles, right? And it's real, right? Before you didn't see that, but now, so I came across someone who came to get food and he was talking suicidal thoughts, and I had to make a call to someone because I didn't know what to do. So one of the fears that I encounter, and by the way, this course is amazing, okay? But one of the things that I was concerned about, what is that process or what does that look like where you're like, not only he wants to harm himself, but he want to harm others?
Yeah. No, when we think about capacity, right? Often there can be in some preclinical presentations, not all, there's a fine line between harm to self, violence towards self, and violence towards others. So I do see that occasionally. But I think that in those moments, really, I think getting that additional peer support when it comes to that initial suicidal thought, or someone trusting you enough. So first off, you must be doing good work because that person trusted you enough and felt comfortable enough to share that they were having suicidal thoughts, which is very scary to do. So I just want to acknowledge that you must be that type of person where people feel that sense of comfort and safety. But I think that that peer support piece, right, of getting some additional training, whether that's QPR, everyone can engage in suicide prevention. I don't believe that clinicians are especially skilled in doing this work better than anyone else. In fact, often with my own clients, I feel like they get more help in a suicidal crisis from their peers and family members who can understand. They often do a better job than I could as their clinician. And I think it's because of that relatability and understanding. So there's definitely I would encourage maybe additional trainings. There's QPR, mental health first aid, and there's probably more if anyone knows more, assist training that are all kind of these frameworks for any person to be able to both engage in the suicidal wish, assess safety, and then yes, there is a point where you make that call to further assessment as needed, whether that's calling 988 with the person. Yes, and your TSPN regional director can coordinate for a local training for you, but those local trainings can be really, really powerful. And so that everyone can engage in suicide prevention. Did that answer your question?
Yeah, it's in a nutshell. I'm just kind of recap. So what I'm hearing, because this, I kid you not, this is so amazing. What I'm hearing is it would be helpful for me to seek other like suicide prevention, mental health assist training in those kind of avenues to broaden that. And what could, because fear is a normal reaction, right? I'm like, oh my God, inside, right? And I made a call to someone and they were like, just let him talk.
Yes.
Let him talk. He talks his way out of it. And I'm sitting next to him and I'm like, oh my goodness. And I've never experienced that. And that is why I'm here. And I'm really thinking about changing my career, but you've really helped me and I will definitely seek training. This is unbelievable. People are hurting.
Yes.
And it's a hurting world. So we need more light like you. So thank you for what you do.
Well, and really, I think the most important thing, the advice you got from your colleague, let him talk, right? And
Yes, she
that's
said.
really sitting and empathizing with the wish. That is the most powerful intervention that we have, and that does not require a master's degree to do.
Yeah. Wow. And that's so real. Because we're always human nature, we're always on the defense. It's our number one thing is to defend. And when you don't defend and listen, one of the things I was very clear to me is he lacked value. Nobody cares. Nobody cares. And it's just sad. But without saying anything, body language shows that you care. I didn't have to say a word. All I had to do was look him in the eye and be attentive and show that empathy. I didn't even have to say anything. It was unbelievable on how it turned that around. So thank you for everything you're saying. I will definitely seek more into this. So I appreciate it.
And I think what you're describing really is what people in severe pain want. They don't want false hope or solutions or problem solving, right? They're too distressed, right? When you're in a suicidal crisis and in that much pain, your rational brain kind of goes offline. And so you really are just in this primitive state. But what people need in those moments is just a witness. They
Mm,
need someone to see them.
yeah, and it's powerful. Oh my goodness, it's amazing. And you've made it real to me. I've experienced it. And the gentleman did come back maybe 2 weeks after that. And when I saw him and I opened the door and I was like, "How are you?" And you know what the first thing he said is, "You remember me." I was
Yeah.
like,
Yeah.
wow. And so I appreciate you for everything. This is amazing. And I'm a true witness of it.
Yeah.
I don't have a degree in this at all, guys. At all. Okay.
Well,
I
you
don't
don't need one.
license.
You do not need one to do to empathize and to connect with another human.
Yes, ma'am. Thank you so much, guys.
Yeah, I love that. Motto, you holding space was and is enough. And I think that for me as a clinician, right, and thinking of patience or tolerating the risk, often that is what I remember, right? When a session just seems to go nowhere, did I hold space? And that is enough.
Yeah, that is so real and so genuine. And I'm so sorry, it shows my profile as my phone Motorola.
Oh, that's not your name.
Okay, I thought that was so cute. I know. I was like, oh, I see where she get that from. So my real name is LaDonna, like L.A.
Okay.
Donna.
Well
Yeah,
done.
yeah. So, but I witnessed that myself. That was adorable. I'm gonna tell people to call me Moto right now, just for the day. So it was beautiful. Thank you.
Thank you.
I have a Motorola phone, so thank you. I'll give somebody else a chance.
Yeah. Yeah. Any other questions or thoughts? Feel free to put them in chat. Or things that you want me to spend more time on. Yeah, absolutely. Yep, that community response to suicide prevention probably is the most powerful thing. Um, well, if no one else has comments, but feel free to put in chat. Maybe I'll dive into a little bit deeper into what I briefly presented in the first part, if that's okay, and share a few different things. I'm going to okay, I have a question, so I'm going to answer that first. CPR, certified peer support specialist, I'm guessing. Please correct me if that's incorrect, Donna. But encouraged to share our lived experience. Would my past experience with suicidal ideation be helpful to share? Yeah, certified peer recovery specialist. Got it. Thank you. Yeah, in my experience, yes. I think it can be that peer support can be extremely impactful, and provide a great deal of hope. It's always dependent on the person, right? And I think you, as a, peer specialist, get a sense of that. But yes, I think it is very powerful for myself as a clinician who has my own lived experience, right? Um, at I generally do not with my clients share my own lived experience, because it can kind of struggle with the therapeutic relationship. But if I'm in a different role, if I'm interacting as more of a peer or just a community member, then I may share about my own suicidal crises when appropriate. So yeah, I think that the more that we can normalize suicidality, and recognize, then it feels less isolating, right? Because often the big fear that people have experiencing any type of pain, but I think especially with suicide, is it can feel so isolating. I'm the only person that feels this way, or it's wrong to feel this way. When, as we know, it makes sense, right? It makes sense to have suicidal fantasies in the context of people's lives. So I think it can be really, really helpful. Yes, when hospitalized, I'll share a story about that. I was doing a group when I was a new clinical director in the hospital, and I had a new clinician shadowing me. And I felt pressure to do a really good job. She was shadowing me running a group, and we were on a group, and it was actually a detox unit. So we were running a process group. And the group started talking about suicide, and it very quickly turned into everyone talking about why they should die by suicide. I'm being a little flippant about it, but that's the way it felt. It felt very heavy. Everyone just kind of saying, yeah, I have those same thoughts. Yeah, no, it makes sense. We should. And I felt so heavy at the end. I was in complete fear and panic. And I was probably had more pressure on myself because I had this new clinician shadowing me. So I felt some embarrassment about, oh, that, I could not pull anyone away from the suicidal wish. I didn't see relief even with trying to empathize. And they were all just saying, commiserating over why suicide made sense to them. So after the group ended, I thought, I thought I'm so grateful that all these people are inpatient, even though inpatient is not safe necessarily. People do die by suicide in hospitals often. But I knew that they would have eyes on them and that there was 24/7 nursing staff. And I thought, okay, I'm going to have to check in with each of them and reassess their discharge plan and reassess suicide. When I came back the next day, they all said that was the best group ever. They said they didn't realize how it felt to not be alone. And that being able to talk openly about their desire to die without judgment from their peers. Certainly they may have felt some judgment from me, but I tried to stay mostly quiet. But just having that peer support and saying they weren't alone, they all came on their own to feeling more centered and more hopeful about the future. So to me, it was a really powerful thing that when people find connection and recognize they aren't alone, that is often the most powerful experience. And in fact, this is unrelated to suicide, but when I was the clinical director, I'd often ask patients in the hospital what helped the most, right? Trying to assess what the psychiatrist did, what the therapist did, what the nursing staff did. And I realized pretty quickly that what the professionals did in the hospital was the least impactful for the clients. What they said over and over again was what helped me most by being in the hospital was realizing I'm not the only person struggling. And that was more powerful than any intervention that we could provide. So to me, I think peer support specialists, both in the context of suicide prevention, addiction, and mental health, is probably, and medical too. I think of people with, chronic diseases or chemo, the power that they get from peer support, in my mind, is equally as important, if not more important. than professional support. So, and I think the Zero Suicide Initiative really supports that as well. So all the work that you all do as peer support or recovery specialists, thank you. You are, in my mind, the greatest lifesavers. So, yeah. Sorry, I went off on a tangent there, Donna. But thank you so much for sharing. Oh, major changes in suicide counseling over the past 20 years. Yes. So suicide rates have increased significantly, pretty dramatically since 2004. And in the United States are on an upward track. There's been significant jumps recently in suicide deaths and suicide attempts for adolescents, for children, especially adolescents of color. That has increased in the past. It has been, as if you look at risk factors, right? That has adolescents of color, like Latina or Black adolescents and adults have had historically lower risks over the past 6-7 years. That has increased dramatically. And I think suicidologists are still trying to understand why. But we have seen an increase in the United States with suicide pretty consistently year over year. There was a brief respite actually during COVID, but then post-COVID, the rates have continued to increase in the United States. And I think that's where suicidologists are really working in organizations like the Zero Suicide Initiative and Tennessee Suicide Prevention Network. All of those organizations are really working really hard to increase that peer support and provide trainings like this so that we can address that unmet need. And I would encourage you go on to, I'm sure that the Tennessee Suicide Prevention Network has resources, as well as the Suicide Prevention Resource Center and American Foundation for Suicide Prevention. And when you all get the handout, which will be sent out next week, I'll include resources and links to additional trends. Oh, yes. Yeah, LGBTQ plus umbrella, and the use that is a significant increase in risk, and there's been a lot of research about that. One thing that's interesting about LGBTQ youth rates in the United States, suicide is the #2 cause of death for ages 10 to 24. And so the rates are quite high for youth and much higher for LGBTQ plus youth, identified youth. When what research has shown, although it's preliminary, is that when youth or adults are in supportive environments, their rates revert back to normed with their peers. So there is certainly a link between discrimination or discriminatory practices, both within families and communities, and suicide rates. That seems to be consistent throughout history and varies. So yeah, I think that's something that it's important for us to be aware of and recognize. And when we're working with any individual, right, who feels marginalized in any way, which really can be all individuals can feel some sense of marginalization based on where you live, in recognizing that and increasing connectedness for that becomes really important. Thank you, Anya. Sounded like someone might be wanting to say something, so. Okay. Yes, please continue to ask questions, but I did want to follow up with one thing that I talked about, which was sharing risk. And then I can also talk about suicide-focused behaviors real quick. So maybe we'll just, sorry, let me get to computers being slow. Okay, we're just gonna. Okay. So hopefully you all can see I'm not doing PowerPoint mode just because it will make it easier. I want to share with all of you, if you're clinicians or work in this space, there's an amazing organization, the Coalition of Clinician Survivors. They have a great listserv and a ton of resources because it is important. This work is hard. And I think that engaging with others and getting support when it comes to postvention for clinicians or behavioral health peer support specialists is critical. I did want to talk about from the suicide initiative, it is one of their to engage in evidence-based treatments. And I talked about the we really need to, if someone is suicidal, we need to be doing suicide-focused treatments and treatment planning. Here are some of the evidence-based treatments that do have some RCAs and more research under them. Although I want to acknowledge that really any suicide-focused treatment for your clients can be important. But dialectical behavior therapy certainly has a lot of support. I always include no treatment up there because I think that that is an option. Then a right that individuals have is to not receive formal treatment. A lot of individuals that I know feel like peer support is their best way towards recovery for suicidal thoughts, and that has been quite successful for them. CAMS, which is Dr. David Jobs, the Collaborative Assessment and Management of Suicide Risk, is an amazing approach that can be really targeted with whatever theoretical orientation or treatment modality you use. Cognitive behavioral therapy for suicide prevention, and the newer brief cognitive behavioral therapy for suicide by I just blinked on his name, Craig Bryan, sorry, and David Red, I believe. That's can be a really excellent, and they have free training for that on the Department of Veterans Affairs website. Some other therapies, conceptual therapy, which is a newer therapy, involves a lot of artistic components, and then mentalization, which comes out of the psychodynamic field. So those are all approved, can be helpful therapies. I want to get to, okay, so I talked about helping patients assess their own risk. And when I learned this, especially with chronically suicidal patients, this was game changer for me and my clients. So the way is to basically a 10-point Likert scale, right? Of where individually with the client, you're asking them to assess the intensity of their risk. So thinking about a 10-point Likert scale, this is not validated. This is one that myself and other clinicians, along with clients, actually created during an intensive outpatient program that was specifically for individuals with suicidal behaviors. So really, clients would come in and they would assess where they were at with their suicidal thoughts. So, from fleeting thoughts that they can, use healthy coping and grounding skills to more increased emotional intensity, but they are still capable of self-soothing, to more high-risk behaviors, so actively using, challenges with coping skills, and they may need some external support. So this would be a cue, hey, I need to start engaging with that safety plan. 2, 7, or 8, where they're starting to have more intensity in suicidal desire with some intent. And then 9 and 10 would be those high-risk behaviors. When I started to have clients begin to self-assess, what it did for me and my clients was helped ground out of the dichotomous black and white. You are either suicidal or you are not, right? And the reality is that suicidality occurs on a spectrum. People have varying degrees of suicidal. If I were to ask a lot of my patients, are you suicidal? The answer would always be yes, right? Even when they're in their most least, happy, excited for the future, they may still experience passive suicidal ideation or have that suicidal desire. So instead, I can just say, where are you in your suicidal thoughts, 1 to 10, right? And that has been really game-changing for me and for clients, because it helps me know how I need to engage and recognize that not every suicidal thought is a crisis. It is just a communication of a problem or some pain, right? There's very limited times where I need to treat someone's suicidal thoughts as a crisis. Here's the CAMS from Dr. David Jobs. He actually does a suicide status form every session. And so you rate 1 to 5, and you can purchase his book, and he has trainings as well. The clients really rate this overall, and it gives you a good picture that you can track over time. So it can actually become an outcome measure. More recently, I have started to create with clients their own individualized suicidal intensity scales. I have a client who has her scale 1 to 72. I have no clue why she picked 72 as the top number. And we individually rate, what does this look like, right? Because for each person, some people can live in a high intensity suicidal state, they've existed in that for a long time. So they may not need as much intervention, even if they're at a 7 or 8, than another person who normally at their baseline is at a 2 or 3, if that makes sense. So more recently, I really work with patients and they create their own individualized, collaboratively understanding as part of that suicide risk assessment. Which is really, when I think about suicide risk assessment, this is what I'm really focusing on, is what are their baseline risk factors, what things increase their suicidality, individualized for that person, what are their symptoms, what are their beliefs about suicide, how much can they engage in behavioral controls or impulse control, because that may impact my safety planning, and then always looking at protective factors or reasons for living. So I just wanted to share that because I didn't have time in the earlier session to really talk about that in more detail. Wondering, we've got about 20 minutes left, so I wanted to pause and see if anyone else had any comments or thoughts, or I'm happy to talk about documentation and risk management. But wanted to do what feels, what you all feel like you need the most. I know it's been a long morning and it's a heavy topic. Documentation. Okay, Crystal says documentation. Let's do it. Documentation. I don't know about you all, but I did not become a therapist to spend hours documenting. And so it is probably my least favorite part of my job and often the most important. Often there is a tremendous fear, part of the fear, at least for me as a clinician, when it comes to clients and their desire to die by suicide, is that I am afraid of being sued. And although I have never been sued individually, I have worked for organizations who have been sued, and I have experienced threats of lawsuit following an adverse event from a client. So one of the important things to remember about documentation is that for a wrongful death, the plaintiff must prove that there has to be evidence that the clinician had a duty of care, right? Which really is that professional relationship. So thinking about in the context of a healthcare provider system, there has to be some evidence that the clinician or systems, there was some dereliction, right? Meaning that we did not do what we were supposed to do. That might be not following policy and procedures, right? Not completing suicide risk assessment, and there has to be damages. And it has to be foreseeable. What this really means is that we are not held liable for not being able to predict the future. So no one, I shouldn't say no one, but the suicide research in liability really states that lawsuits are rarely successful because someone died by suicide. That's not a reason for a lawsuit. The reason for the lawsuit is that the provider did not assess or document suicide risk appropriately. And that's really the biggest problem that comes in, and often where we struggle, right? And often we have a tendency to not want to document suicide risk for fear of liability, but we should actually be doing the opposite. And I'll explain why. Preventing malpractice is providing good clinical care. So that might be following the zero suicide initiatives, following your agency practices. If you assess every person for suicide, assess every person for suicide, right? Consulting and referring when necessary, and we need to be documenting those consultations. Building a therapeutic alliance can be the most powerful malpractice prevention, and then documentation. So when we think about documenting, okay. Sorry to give you all Zoom whiplash there for a minute. Questions to ask yourself when documenting is what specific information from my knowledge of the client's risk and the extent of their suicidal behavior, support the conclusion that I am about to write? Would these facts appear to support my conclusion to another competent clinician? What that means is thinking about the story I shared with you all, where I had a client who was experiencing intense suicidal thoughts, was being discharged from the hospital, and reported having thoughts of wanting to die by suicide with her firearm, right? Had she hurt herself and shot herself, right, post-discharge, my documentation needed to support that my approach to having her write the card collaboratively and tape it on the handgun versus keeping her in the hospital indefinitely. In Utah is very pro-gun, so removing the firearm was not an option. But that made sense and that was a reasonable plan, right? As long as my plan was reasonable and it's documented clearly, and I also consulted on that and documented my consultation, then if it makes sense, then I would not be held liable, in theory, if that person were to die by suicide, right? So I really need to have the entire narrative picture of the client's suicidal experience, complete, objective, and accurate. And then I always ask myself, would my client agree with my assessment? And if not, document why I have a different perspective. So often I have found that people tend to want to document less when there's increased risk, when we should actually be documenting more, if that makes sense. So we want to document our rationale much more in depth with a client who has chronic suicidal behaviors. And we need to have a suicide-specific treatment plan and clearly state that the goal is not to eliminate suicidal behaviors, but for the client to manage the behaviors. So if I'm not hospitalizing, even though my client is reporting a 9 on their 1 to 10 suicidal intensity scale, right? But I'm not hospitalizing, I'm being very specific in why I'm not hospitalizing and why hospitalization may actually increase the problem, if that makes sense. We want to obtain and document a thorough psychosocial history. Really important with suicide risk to obtain previous medical records. Actually, I think it's best practice for all clinical care, but especially suicide risk. If we permitted, we want to document conversations with family members and supports. And if we don't have consent, we want to document our attempts with the client. So often, I have some clients who just will not consent to allowing me to talk to their spouse or other family members. And I'm revisiting that often and documenting my attempts to gain collateral contact. When it comes to suicide, we want to have consistent suicide assessment throughout treatment. For me, when I do those rating scales or if I'm doing CAMs, that may be 5 minutes of every session, right? Where I'm just documenting where are you at, or I'm doing a brief Columbia follow-up every session. And I want to document that every session. And then safety planning, that's not a one and done. We're going to have a copy of our safety plan, make a copy of the patient safety plan and update it constantly and document lethal means. I put diagnosis suicide. We don't have a suicide diagnosis, but what I mean is if I'm working with someone and they have chronic pain, I am also, and suicidal thoughts, I am putting that somewhere in my diagnostic formulation. If they have major depressive disorder with suicidal thoughts, I am writing that in there. And then always we want to document both our consultation and client engagement. And when I send out the handout, I can certainly share some additional language that I use or how. But in general, my when it comes to, I think of whenever I'm documenting, I think of a few assumptions. And my main assumptions of everything I write clinically is that, first off, my client is going to read this. Right? So I need to make sure that it is congruent and that my client agrees with what I'm saying. And if not, that I'm explaining why it's different. So I assume every piece of document I write, my client's going to read it. I assume it will be read by a supervisor in an audit by an insurance company. They're going to read it. I also assume it will be read in court for a lawsuit. And most importantly for me, I assume that it will be read by another care provider. I always think of if I get hit by a bus or decide to go live in Mexico and sell necklaces on the beach one day, I want to make sure that someone else, another clinician, can pick up on my cases and continue to provide care. So my documentation should be available and understandable to another person to continue that person's care. Those are my main assumptions that I think about whenever I document. So I hope that's helpful. If you take anything away about documentation, it is when it comes to suicide risk, write more, not less. So often in the hospital, I saw clinicians and psychiatrists who would write at discharge, client denies any suicidal thoughts, intent, or behaviors, right? And I know that's not true. The client's here for a suicide attempt. They were suicidal that morning. You ask them that day of discharge, and that's all you're writing that they deny, right? Better way to phrase that would be when asked at discharge, client denied. However, during the course of the hospital stay, the patient had fluctuating intensity and suicidal thoughts. And here's their safety plan and why discharge is still the most appropriate action. And I think that that is much more protective than a blanket denial. And we're so, for our own fear, we tend to want to deny, but it's much more important. Yeah. Yeah. Just be honest. Say what you're thinking and why. And that makes all the difference, both for us, for our clients, and certainly if we ever have to do some retrospective or root cause analysis, it becomes very clear. Yeah, please go ahead. I'm just curious what you all are kind of thinking or lingering questions. I know it's been a lot of content this morning, but we've got about 5 minutes, so I just want to see if there's anything else that would be helpful to you all that I could share or that you all want to share with each other. I imagine there's a wealth of experience here. Yeah, I see that, Erin, about documentation. In the handout, I'll include more details about documentation. So that will be much more in-depth. Well, I know, I think, I guess just some final thoughts, as we wrap up. Oh, talk about. Oh, passive suicidal ideations, um, plans on taking their own life if this trial doesn't work. Um, oh, that is so hard. So I think that that's often the case, right? So that ambivalence and really thinking about it's always the get out of jail free card or the escape plan, right? So if this doesn't work out, I can always do that. In my experience, I treat that just like any other passive suicidal thought and recognize the inherent hope in delaying suicide, right? So what the person is actually communicating, although it feels so terrifying, is I have sufficient hope in myself, in this treatment, in this work, that I'm willing to put off my escape from pain for a period of time. And what I have found over and over is that in many cases, it gets put off again and then again, right? As connection increases and the clinical alliance and even small gains in progress improve, people, even if they aren't, not sure what cure it is or if that even exists, but even if they haven't received all the results they wanted, if there's any measure of progress, or even if there's still a chance or a hope, then people often will continue to try, but often still have that if this doesn't work, I will end my life plan. That tends to never go away. And that's often, you hear people talk about it, right? Well, if this doesn't work, I can just kill myself, right? And that seems to be comforting in a way to increase their hope. So it's kind of counterintuitive, but in one sense, it makes a lot of sense, right? That we can endure trials if we know that there's an end date. I quit smoking about, oh man, 15 years ago. And that was the hardest thing that I ever did. And the only way that I am still now smoke-free is that I know that when I retire and I'm living on the beach and I'm 75, I'm going to smoke cigarettes again. The fact that I have an out, that it's possible to do in the future, allows me to not do it right now. And I think a lot of times when it comes to suicide or even with addiction, right, in relapse prevention, it's often very similar. Taking things off the table forever feels too hard. Seeing Ashley said, assess for suicidal ideation and whether or not they have the means, physical ability to commit suicide. Yeah. Yeah, no, it's very, I think it's really interesting. I will just share one thing, and I know we're at time, but in my work with suicidal people, I've worked with a lot of people who have been in treatment for years and years who have never talked about their suicidal thoughts with a clinician. Because it hasn't been safe to. And I don't fault the clinician for that. I think it's just not something that we talk about or know how to deal with until more recently. So I want to thank you all for coming to this training and beginning to focus a little bit differently on suicide. And I just encourage you to shift your focus. We prevent suicide by improving life, not preventing death. Thank you all so much, and feel free to reach out. Yeah. Is there anything else, Lisa? Oh,
Yeah.
go ahead.
No, so what I see is that we're coming back at 1. Is that correct, Anna? We're gonna take a look.
Yes, and one will go through, just if you want to come back, it will be a little different. We may have a teensy bit of overlap, but it'll be much more medical. And I'm actually walking through an entire case study in a medical office with a suicidal individual. So it'll be both part content and then part case. So should be fun.
Did somebody have a question before we go on break? It sounded like somebody was coming in. Okay, all right. Go on break then, and we'll see everybody back at 1 and maybe some new folks as well.
Yes, that would be cool. Thank
Okay.
you all so much.
Thanks. Anna, do you say your last name Lieber? Is that right?
Yep.
Okay, good. I've been saying it over and over in my head because I'm going to introduce you this time because Anna has another meeting to go to.
Perfect.
And she asked me if I would introduce you, and I'm like, yeah, I can't. I can do that. I'm real shy. A lot of people don't believe that, and I'm like, hey, let me see if I can say this last name. And I did. Okay, I just need to ask how to pronounce your last name. I should have listened a little bit better. Anyway, I'm just, 'cause I'm not.
It's Lieber because it's German, but it's spelled Lieber, so it's very confusing.
That's what I thought it was, but then I thought I heard Anna say Lieber, and I'm like, oh, it's just okay.
Let me I always panic and worry that I did share sound. Okay, you good?
You don't ever look like you're panicking or worrying at all, so you play it off real good.
That's what people tell me. I don't know how.
We fake it till we make it, don't we?
Yup. No, but I am really, I guess, passionate about this topic, so it makes it easier.
Well, you can definitely tell by the way that you're presenting. We'll give everybody another minute just to
Yeah.
get back on.
No, 30-minute breaks feels like a long time, but it's really not. It's goes by quick.
It's not. I was in there rushing around trying to, yeah, I'll just go ahead and admit it, trying to eat some chips
Yes.
and get something to drink and empty the dishwasher. Thing I know, it's like, oh my goodness, let me get back in there. Okay, and are you ready to get started?
I am ready.
Okay, I think everybody is from last time, but anybody that's new, Anna Lieber is our speaker today, and she's been talking all things suicide related. And Anna, I'll let you present yourself better than I have. I just know that you've been doing a great job so far, and thank you so much for being here. We greatly appreciate you.
Thank you all so much, and I'm really excited to be here. Yeah, I'll just introduce myself briefly and kind of talk about the structure for our next 90 minutes and then subsequent hour. Um, so I'm Anna Lieber. I'm a licensed mental health counselor. I'm currently in Salt Lake City, Utah. I have worked in Utah, Florida, primarily. My past experience, I really was a chief clinical officer of a large psychiatric hospital and have worked in all levels of care. So for this presentation, it is really focused more on behavioral health settings, excuse me, medical health. So primary care settings where I'll be focusing on how we can integrate suicide prevention in those settings. And I'll share why that becomes so important and how suicide can be prevented throughout all levels of care. But I think especially nursing staff, CNAs, and medical assistants play a tremendous role in suicide prevention, identification, and screening. So this presentation really will be a case study. So we will walk through a fictional case, although the case is fictional, it is a collaboration of multiple clients or similar clients that I have seen throughout my career. And then for the first 90 minutes, if you have questions, please utilize the chat for this first portion. After that, we will take about 2:30, we'll take a 30-minute break and then come back for our final hour where I will dive more into skills of how you could implement this in your healthcare setting, additional resources. And then really my intent with that second part really is to answer your questions and learn from you and hear your experiences of what's worked, what hasn't, and how we can all collaborate together. I have no financial stake in any of the clinical treatment resources or books or theories that are mentioned. I will also each of you will be provided a detailed handout, including select slides, references, and links for further education. And that will come to you sometime next week. Really important to just recognize that ultimately each of you are responsible for your own clinical decisions. Everything I'm presenting is grounded in research and best practices, but no guidance outweighs the information you and your patient have about their situation. So I encourage you to adapt these skills or concepts learned through your own clinical orientation, work practice, comfort level, and skill. I think it's really important anytime I talk about suicide, that we focus, I guess, on acknowledging and honoring the tremendous work that each of us do. I also recognize that many of us in this room are individuals with our own lived experience and suicide loss survivors. By virtue of attending this training, all of us are interested in embracing this work and managing the pain and joy that comes from engagement with the suicidal wish. So I think this topic is hard. It brings up a lot for all of us. And we are all connected. So even in this virtual space, we've got 44 people who are interested, who we can connect with and seek support from. And I think that that's important. The Zero Suicide Institute is a tremendous resource, and certainly I have adapted a lot of what I'm sharing from the Zero Suicide Framework. Today, I'm specifically, well, by attending, each of you are getting training as one of the core pillars of Zero Suicide. I'm also going to work through helping you begin to identify suicide risk, engage with suicidal individuals, treat so which is appropriately intervene with suicidal risk. And then we will talk about transitions in care, will be our focus today. When we think about suicide, it's really important to use sensitive and first person language. Sally Spencer Thomas, who's a suicidologist, states the litmus test for talking about suicide is to substitute the word cancer for the word suicide to see if the sentence still makes sense or if it has a negative connotation. For example, we would never say someone committed cancer or they had a successful cancer. We would simply say they died by cancer or had a cancer death. So similarly, when we talk about suicide, it's important to use sensitive language that helps to decrease the shame and blame and stigma, right? So we don't commit suicide, we don't commit overdose, we die by overdose, or we have an overdose attempt. Similarly, thinking about successful or completed or failed suicide, successful generally means positive, and certainly when someone dies by suicide, in my mind, that is not a positive event. And failed indicates that someone made an error. When it should be a fatal versus non-fatal suicide attempt. I think that that's just really important. Similarly, first person language, people are not defined by their symptoms or their diagnoses. So we want to encompass the entire person. So Anna has lived experience with suicide versus Anna is suicidal, for example. I think that this becomes really important. One thing I will say is I do not correct patients. So I that may reinforce shame to them. So if my clients say their aunt committed suicide, for example, I'm not correcting their language, but I would refer to it as when your aunt died by suicide, what happened? Similarly, if they use successful or failed. So I use the correct terms, but I think it's important to not correct patients. I do correct staff and colleagues because I think this language is important. Brief suicide statistics in 2022, almost 50,000 people died by suicide. As of 2023 and 2024, that has risen to over 50,000 now. This works out to one person dying by suicide every 10 minutes in the United States. Suicide is a public health issue, and many organizations, including the Zero Suicide Institute, are a crucial part of the solution. Even though so many people die by suicide, in my mind, there is still a tremendous opportunity for hope. And this is really what I mean by that, is that of a tiny fraction, right? So less than 1%, 0.34 to be exact, of individuals who experience serious suicidal thoughts die by suicide. So there is still a significantly low, although far too common, base rate for suicide death. When we think about how many people, over 12 million in the United States, are currently experiencing serious thoughts of suicide, that tells me that we have a tremendous opportunity to engage and hopefully help prevent the increased suicide death. And there are multiple, this slide only reports on non-lethal suicide attempts and suicidal ideations. And I think it's important because suicide is not a linear process. There are many ways that individuals experience suicidal behavior. Most individuals who attempt suicide did experience suicidal thoughts and make plans prior to the attempt. However, many do not. So we can see here that 1.3 million individuals had serious thoughts and made plans and attempted, but many people who attempted suicide did not have serious thoughts of suicide, only attempted suicide, right? There are multiple pathways that lead people to engage in suicide attempts. And to my mind, this often speaks to the impulsivity and the crisis and unpredictability of suicide. What we know about the suicidal crisis is in that intense state. The suicidal crisis lasts typically 5 to 30 minutes on the outside, maybe an hour, but it is a brief rupture, intense emotion that leads someone to engage in the act of making a suicide attempt. Very short term, and that's where crisis safety planning becomes so important, and we'll talk about that today. We want to understand the suicidal mindset. When I think of being suicidal, I think of it as a state of being. It's like being depressed, like being anxious, or being hungry, or being in pain. Suicidal presentation is transdiagnostic or presents without a diagnosis. And this is really important because too often we think that if the person does not have a psychiatric problem, that they aren't at risk of suicide. And the research shows that to not be the case. People can present with suicidal behaviors for a multitude of reasons, including physical health problems, social economic problems, irregardless of having a mental health or psychiatric disorder. Also really important to recognize that suicidal thoughts and behaviors can be either or both comforting or distressing to patients. Suicidal behavior is often a solution to a perceived problem. It becomes a coping strategy, a way to manage the pain, either physical or emotional pain that a person is in. What's important to remember is that suicidal behaviors or having suicidal thoughts does not automatically indicate that the person is mentally ill or that they are in crisis or this is an emergency. It just indicates that there is a problem. So it's a communication of pain and additional resources being needed. There are many theories about suicide, but Thomas Joyner's interpersonal theory of suicide is one of the most influential. And what it really shows is that this little triangle, if you can see it right there, that is the lethal or near lethal suicide attempt. And so what kind of convalesces there is there has to be a desire for suicide. The person often experiences thwarted belongingness, feeling alone or isolated, perceived burdensomeness. I am a burden to myself, to others, and they have to have the capability for suicide, which is both a combination of access to lethal means and the capacity to enact in that level of self-directed violence. So these are the areas that we're assessing in treatment planning and safety planning around. When it comes to healthcare providers, the zero suicide framework is pretty clear that people who are dying by suicide are seen by healthcare professionals before their death. One study showed that 95% had seen a healthcare provider in the year before their suicide attempt. 38% saw a healthcare provider the week before they attempted suicide, and 19% had contact with a mental health professional in the month before their death. We also know that many people are seen in emergency departments shortly before their deaths, or discharged from a hospital, either psychiatric or healthcare hospital, shortly before their death. Healthcare professionals at times fail to ask about suicide risk, either because they were never trained to or don't know how to recognize suicide risk. The Zero Suicide Institute and suicide best practices really indicate that we need to be treating suicide risk as a public health crisis, meaning we ask everyone. And the research really shows that asking a person about suicide has absolutely no impact on increasing risk. So the common myth that talking about suicide will make someone in pain suicidal just does not bear out in the research. It actually probably does the opposite. And talking about suicide helps alleviate suicide risk. For our training today, we're going to walk through an entire best practice steps. We're going to start with identification and screening, and this is a universal screening. Suicide risk assessment, safety planning, assessing for environmental safety, level of care determination, follow-up, and then briefly talk about support for healthcare providers. The Zero Suicide Institute and best practices really indicate that we should be screening individuals for suicide at all touch points of healthcare contact. There are many standardized screening assessments, PHQ-9, ASQ, and many others. Really important to review all patients' personal and family medical history for suicide risk factors, and to ask directly about suicidal thoughts and plans. Once you start screening, it often can feel like an increased burden to healthcare systems and providers, because then now what? Now what do you do as people start to report more suicidal thoughts? I'm going to walk you through a case that will show you what you can do. Here's our case. John is a 45-year-old male, white Army veteran who presents to his primary care provider due to increased lower back pain. John reports he was helping his brother with a construction project and strained his back. You have met with John previously, and his medical records indicate he is a divorced father of 2 daughters, ages 10 and 5. He retired from the Army 2 years ago and has had difficulty finding employment and adjusting to civilian life. He has a previous back injury sustained during his military service and experiences intermittent pain. He has difficulty sleeping and has been prescribed melatonin, which was working well as of the last visit 6 months ago. He is in good health with no chronic medical conditions or previous psychiatric diagnoses. We'll say this primary care physician's office instituted doing a PHQ-9 with all patients upon intake as a regular intake questionnaire. And here is John's. So I'll give you all just a moment to look through it. And what do you notice about this PHQ-9? And if you feel comfortable, feel free to put in chat what you see. Yep. No question on number 9, right? It was omitted. You know, sometimes people are in a hurry, and it may have been omitted inadvertently, right? But if we're looking at these, really important to look at these before we meet with the patient, because we don't want to miss this, right? Too often I've seen clinicians or healthcare providers look at the intake questionnaires after the person leaves and then have to follow up in some way when these things were omitted. So here's how it looks. John, I noticed you did not answer number 9 on this form. It seems like you have been struggling with some pain, and I know adjusting to civilian life has been challenging. Are you having thoughts of hurting yourself? What's interesting is this professional recognized that there were some elevated answers on this, right? So it's not just, oh, you didn't fill this out, but there's some elevated things, especially the sleep, right? That indicate that John may be at some risk. And knowing John's history, we want to do a more in-depth question about this. So this is how they collaborated it to open it up if it is positive. John responds by, well, sometimes I guess. My dad killed himself when he was 46, and my life is just a mess. I just don't know. Notice, John doesn't really answer the question, right? He kind of skirts around it. Professional. Losing your dad must have been really hard. Thank you for sharing that with me. Have you been thinking about killing yourself? There it is. When people skirt around it, and if we ignore it, we are then colluding to silence the suicidal thoughts. So we need to be very direct. John, yes, most days I wish I could just go to bed and never wake up. I fantasize about blowing my head off just like my dad. I just think everyone would be better off if I weren't around. All I do is cause pain. But I wouldn't do it. I don't need to go to the hospital. It's just thoughts. So the professional's response created a sense of safety for John to be more honest, but then he quickly responded, don't put me in the hospital. When I hear such a strong response from a person, our first instinct as healthcare providers is to do this. I don't know about you all, but that's my panic button. I hear someone, an Army veteran who likely has firearms, wants to shoot himself in the head. My panic button goes off immediately. What I'm hoping we can all learn to do today and moving forward is when that panic button goes off, to breathe and slow down. We have time. John is in our office. He likely does not have a firearm with him right now. We have time so we can slow down. And the most important thing we can do in this situation is actually use empathy, which is a skill all healthcare professionals have. I'm going to show a brief video about empathy and what it is.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, you can climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. And we do it all the time. Because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So, I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now, I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
All right, let me get my screen going again. Hopefully you all could see and hear that okay. That's Dr. Brene Brown talking about empathy, and I think it's a really beautiful illustration of what's important in these critical moments when our panic button goes off. So the first thing we can do is to engage in empathy, and especially with the suicidal wish. When we can empathize with the suicidal wish, really magical things tend to happen. The patient's pain actually lessens. As Dr. Brown illustrated, right? When we feel that connection, if we've ever had something really hard and someone just says, "Ah, I'm here with you," don't you feel a little bit better? You aren't alone anymore. Most importantly, we also teach patients to tolerate their pain. If we can tolerate their pain and their experience, then they feel more capable of being able to tolerate their own pain. It's also really important, especially in a suicidal crisis, to teach patients or to demonstrate that treatment and process is more important than action. The last thing I want John to do in this situation is to feel like he has to act. I want him to slow down and to be more considerate in the face of this suicidal pain. And so I need to model that. And this really can support the patient's active self-healing. What empathizing with the suicidal wish really looks like is we just sit with and honor the patient's emotions. We meet them where they're at. We need to manage our own panic buttons and emotions. We have to maintain a neutral stance. And we want to just understand, right? If experiencing suicidal thoughts is not necessarily a crisis or a sign of mental illness, but an indication of a problem, I want to understand the problem, just like we would whenever a patient comes and is complaining about any type of symptom. We want to understand. We want to figure out, why do you have this problem? Where's it coming from? And that's what we want to do with suicide. We want to avoid fixing, problem solving, and comfort giving to be able to empathize with the suicidal wish. So for John, the provider remembered to slow down and empathize and took some deep breaths before responding to John. John, thank you for trusting me to share how you are feeling. It sounds like you are in a tremendous amount of pain and worry that you cause pain. I would like to better understand these painful emotions. Can you tell me more? This is often before we jump into a standardized risk assessment, just asking, tell me what's going on, becoming curious. John, I just don't know how to go on. Every day I wish I had died overseas. I can't function outside of the military. I worry for my children, but what use am I to them? I know how challenging things have been, and sometimes when people are in both physical and emotional pain, it can be really difficult to find or conceive of a solution, and suicidal thoughts can feel comforting, like a way to escape. Yes, that is often how it feels, like a welcome escape route, and other times it is scary, like that really is my only option. When we can engage, we really learn a lot, right? So for John, his suicidal thoughts are both welcome and comforting and scary, right? He's afraid of dying. Part of him does not want to die. And that is that ambivalence that we can really lean into and provides a tremendous amount of hope. Professional, I'm wondering if you are open to working with me now to see if we could find some solutions together and for us to complete an assessment to better understand your suicidal thoughts. Are you okay if we complete a suicide assessment and safety plan together? So thinking of in the context of a busy primary care office, this empathy doesn't have to take a long time. It is taking a few moments, sitting with a person, and then seeking consent to engage in continued, once we've identified suicide risk, to engage in suicide risk assessment. It really can be fairly quick. Some helpful statements. When we're communicating with clients, we want to focus on life symptom improvement, not on preventing death. It's really if we can focus on helping someone improve life and not just preventing death, we actually have a better chance of preventing death. So it's a better prevention. It's counterintuitive, but when we can stop trying to prevent death, we actually improve our prevention efforts. We want to empathize. We want to normalize the suicidal thoughts and the desire to escape. We want to help someone feel less like a burden or less alone. It's important to view suicidal behavior as a protective coping strategy and then always lean into that ambivalence. Okay. So we identify, then we empathize, and then we get consent to do a suicide risk assessment. When we think of suicide risk, I think there's a lot of misconceptions about suicide risk assessment. Often we think of suicide risk assessment as determining who will or who will not die by suicide. So if we look at this person here and they say, I'm going to jump, what might our initial response be? Mine would be don't jump, right? Someone says they're going to jump off a balcony. I would say don't jump, right? And often that is our initial response to suicide risk. I need to figure out who's going to jump. But actually, the purpose of suicide risk assessment is to zoom out and figure out the context. So hopefully we'd all agree we don't want this person to jump unless we zoom out and we see, why does this person want to jump? Now we might be saying jump. We've got the fire department down there. Maybe they have a big blow up thing, right? Once we can zoom out and see why the person wants to jump or why the person is having suicidal thoughts, now we can engage and identify what the person needs to stabilize, right? So suicide risk assessment is not about identifying who is or is not at risk, but it is about identifying what resources does this person need to support their situation. It's about the symptom identification. Why is this person experiencing this pain? Once a patient screens positive for suicide risk, or you feel more assessment is needed, then we do need to do a more formal assessment. There are many different assessments, the Columbia, ASQ, SAFE-T, AMSR, and many others. And many of them do not require being a licensed provider. They can be done by multiple individuals at any level of care within a healthcare organization. For the purpose of John, we're going to walk through the ASQ assessment. So once the provider has identified a potential risk of suicide and sought consent, then we go through and ask the additional ASQ questions. These can be done where John fills them out, but more often I prefer, especially if it's in person, to do a narrative where I'm just asking the questions and then filling out the form myself. So John said, in the past few weeks, have you wished you were dead? Yes. Have you felt like your family would be better off without you? Yes. Have you been having thoughts about killing yourself? Yes. Have you ever tried to kill yourself? No. Are you having thoughts of killing yourself right now? No. Because John said yes, because John said no to number 5, but said yes to questions 1 through 4, or at least one, then it is a non-acute positive screen, which means that it requires more assessment, but it is not necessarily indicative of an emergency right now. You would want to follow your organization's policies, and that may include alerting the physician or clinician responsible for the patient's care. And then you dive into a more formal assessment. The ASQ is very similar to the Columbia, where there's those initial screeners, and any positive response results in more screening. So the ASQ, the first part is to acknowledge, so praise the patient. Thank you for telling us, right? This can be hard. So normalize the challenge of talking openly about suicide. We want to really evaluate the frequency of suicidal thoughts. So for John, he reports having suicidal thoughts once or twice a day. And the last time he had suicidal thoughts was this morning. We want to assess about a suicide plan. So we ask the patient, do you have a plan to kill yourself? If yes, what is it? If no, if you were going to kill yourself, how would you do it? This is really important. Individuals who have identified a plan or a method often have more than one. So I always follow up saying, what else have you thought about, right? For this case, John denies a plan. A plan would be a date and time of suicide, but states he would shoot himself. So he has a method identified, but no plan or intent at this time. He denied any other suicide method. We also want to evaluate past behavior. Even though that's listed on that initial screening, we ask again because the longer we spend with the person, even if it's just 5 minutes, the more therapeutic alliance builds, and people are often much more likely to admit, even if they denied initially. I see this over and over where even on the PHQ-9, people will say no, but then in session or when meeting with the provider, they will disclose suicidal thoughts, and vice versa. At times they will report it on those screening reports and then not report it verbally to the provider. So I think it's really important to use both in our assessment. So John denies any past suicide attempts or psychiatric treatment. Then we review symptoms. So really asking the patient more in detail, and the questions are all very clear with the ASQ, depression, anxiety, impulsivity, hopelessness. Have you felt hopeless? And then you're just marking where the patient has an affirmative response. Isolation, irritability, substance and alcohol use, If there's anything significant, I make documentation. So for John, it was never when asked about substance and alcohol use. Sleep pattern. He reports trouble falling asleep. Sleep is, there's a strong correlate between sleep disturbances and suicide attempts or death by suicide. So I think I always pay attention to sleep and hopelessness, as well as other risk factors. And then other concerns, right? Any other changes. So for him, he's having an increase in back pain and frustration about lack of employment. We then really want to assess social support and stressors. This becomes really important when we think about safety planning, right? So we ask, is there a trusted person you can talk to, right? John reports my battle buddy. Any conflicts? What's the current, kind of social situation? So conflicts at home, things that are causing distress. For John, it's his divorce. Employment, assessing economic stability. He has a lack of employment, which is causing problems. We want to always assess for violence. And then suicide contagion, which really is, do you know anyone who has killed themselves or tried to kill themselves? For John, his father died by suicide at the age of 46, which is about the same age John is, almost. And I think that suicide contagion often indicates a potentially higher capacity for engaging in a suicide attempt, right? Which makes sense. If you know someone, we know similarly with like substance use, right? If it's, you know someone or you've experienced or been around substance use, it's much easier or more likely that you would use substance use as a coping strategy, and the same applies for suicide. And then we also want to assess reasons for living. So some of the reasons you would not end your life. So for John, it was my daughters and my military friends. I want to pause real quick for any questions or thoughts as we moved through very briefly the ASQ screening toolkit. And mostly so I can get a drink of water. I am paying attention to chat, so please feel free to put any questions in chat or comments that you have. Okay, so now we've done the ASQ suicide risk screening for John. And it indicates that yes, there is a problem. John's suicidal thoughts are indicative of a problem, right? He's also got some strengths and some protective factors. But when we think of looking at his assessment, right, there's a lot of risk factors that are present right now. And so that really requires further intervention to support him with his suicidal thoughts. So again, our goal is to identify, we've assessed to identify what the problems are and why they exist. And then we move forward. So I'm gonna, the way that there's a question from Jesse, thank you. How do you elicit truthful answers when a patient fears and is resistant of inpatient hospitalization if they disclose? That can be really challenging, and we'll talk about hospitalization today. But I think really I frame it as, in my mind, I'm going to utilize all levels of care. And if we can effectively safety plan, then hospitalization is not needed, right? So unless someone is at imminent risk of dying by suicide, meaning they tell me that they are going to end their life in the next 24 to 48 hours, it is very unlikely that I would hospitalize someone. And that would not be best practice, right? So I communicate, hey, if we can work together and we can come up with a good safety plan that we both feel comfortable about, there's no reason for hospitalization. There is a reason for intervention.
Which
Or
not too many people
hospitalization.
come over here really. They pull up on this side more so than that side, but not often. I'm not an online shopper because I like that.
Reminder to mute, please, if you're unmuted. Cool. Hopefully that answered your question, Jesse, and we will talk more about hospitalization today and dive into that. Okay, so once we've assessed, then we definitely should do a safety plan and brief intervention. And again, this can all happen in a matter of pretty quickly, right? So thinking about in the context of a primary care physician, the screening and assessment may only be 10 to 15 minutes long. Longer if you have time, that's great, but I know how busy medical settings often are. When I think of safety planning and brief interventions, a good way to think about it is it's a life preserver. A safety plan is something that we can hold on to that gets us through the rocky times or the rough seas in the event of psychological, physical pain, or a suicidal crisis. Safety plans really are meant to aid in the management. And one of the most powerful clinical interventions we can make when working with a suicidal person is to overtly negotiate putting off suicide to a later point in time. I want to really communicate to individuals that these emotions, the suicidal urgency, feelings, thoughts are temporary, and can we wait them out? And I have found this to be the most powerful tools that clients have to manage a suicidal crisis. And again, the suicidal crisis really is a short period of time. So if clients can say, I'll give it an hour, often by the end of that hour, the suicidal intensity has lessened. What safety plans are meant to do is to really make decisions during acute distress and impaired problem solving. When clients use safety plans, they have an improvement in their emotional state, a reduction in suicide attempts, and a quicker resolution to the suicidal crisis. It also really helps people feel a greater sense of self-efficacy and that they can solve their problems. And I always communicate to patients that a reasonable safety plan is an alternative to hospitalization and is always my first go-to, I would say. There are a few different types of safety plans. It's important to use an evidence-based one, but I don't have a preference of one over the other, so whatever your agency uses. The Stanley Brown, we really want safety plans to focus on personal warning signs. How will a person or their loved one know that you're experiencing increased suicidal thoughts or at risk of experiencing suicidal thoughts? What internal coping strategies does the person have? That might be mindfulness, social distractions, who can provide help, making the environment safe, and in the Stanley Brown, identifying reasons for living. I really like contingency-specific safety planning, which is once we've done an assessment and we identify those specific triggers. So often I'll have clients say, if I lose my job, then I will be really suicidal, right? Or I will die by suicide. If this happens, then, if things get worse, then. So my contingency specific safety plan will be, let's plan if you lose your job, what will you do, right? If the worst thing happens, what will you do? So it's very specific and individualized versus more global. I think when it comes to safety planning, It really is a collaborative process. Our goal is to not control, right? It's those high intensity thoughts that we, the provider and patient, need to plan around. We want to find out what works for them. There's no one size fits all. Is it mindfulness? Is it connection? Is it disconnection? Is being alone better? What do they have? What are their protective factors or things that connect them to life? And are they more, harm reduction things? And then we also want to teach a new skill. This becomes, in my mind, when we think about best practices, we want a safety plan and give them something new. And that can happen very quickly, and I'll show you what that will look like. So here's John's safety plan. So we want to talk about warning signs. So John identified when he isolates or when he starts to have thoughts that his daughters would be better off without him, or he has an increase in anger, right? All of those things indicate that a crisis might be developing. His internal coping strategies, thinking about his daughter's future, meditation, that might be looking at pictures of his daughters on his phone, listening to music or playing the guitar. Where he can go, people or places that can provide distraction. He's got his battle buddy Mike, going to the music store or spending time with daughters. And then very specific, who can I call in a suicidal crisis that will answer the phone and be a supportive help? And it has to be someone that you actually talk to. I remember doing safety and relapse prevention plans, and people would say, my sister, I'll call my sister. And I would say, how often do you talk to your sister? And the patient would say, Christmas and Thanksgiving. Like, okay, well, that's probably not a good person. Who do you actually talk to that that you see regularly? And then making sure that we have professionals or agencies. So 988 for sure, but also local urgent care emergency or healthcare providers numbers. And then we want to make a plan to make the environment safe. And we'll talk more about that. We always want to ask the safety question. Do you think you need help to keep yourself safe? If the patient responds no, that does not indicate that the patient is safe. So I want to be very clear here. But if they respond yes, they need help, then we are given great information about we need more intense immediacy for action, for safety. So I always ask patients to rate their own safety, right? I think that can be a very powerful tool. And then we want to complete a brief skill intervention. For John, I would probably, because of his sleep problems, I would probably do a brief skill intervention about sleep hygiene. And that may be as easy as saying, hey, let's talk about sleep hygiene, and providing John with a handout of strategies he could use to improve sleep, or teaching a brief mindfulness skill. Often with patients, I'll teach them box breathing, or can really be anything. But I think if we can spend 5-10 minutes and teach someone a new skill, that provides an element of hope, right? They start to feel a sense of hope. Oh, I have something new I could try. The other thing I'll say about safety plans is I think of safety plans as fire drills. We do fire drills because when there's not a fire, so that when there's a fire, we know what to do. So I encourage patients to use the same. I say you need to practice the safety plan and do all of these things when there's not a crisis. So just like the fire drill, we are using it and able to access it with that muscle memory when there is a fire or when there is a suicidal crisis. Safety planning in a suicidal crisis is a constant balancing act between client safety and client autonomy. So at times, I'm thinking of alternatives to hospitalization. I have had clients stay at someone else's house, invite someone over to their house. We definitely want to reduce access to lethal means. Sometimes, especially with adolescents, it can be increased supervision. There might be home searches. And at times we want to use higher levels of care. And yes, Alice, we're going to talk about that next. And I always refer to 988 or other crisis lines. Okay, so we've done safety planning and a brief intervention. And a piece about safety planning is environmental safety, but I almost think of it as separate and distinct because it is so important. Lethal means restriction is the most important tool that we have in suicide prevention. And it's important to recognize that lethal means really is, there's a misnomer, I would say, that if someone wants to die by suicide, they will find a way. Now, part of that is true, but more likely when someone has a method identified, removing just that one method can increase safety substantially. What I mean by that is if I'm working with an adolescent and they say, I have a plan or my suicide plan would be to take this specific razor blade and cut my wrists. If I remove that razor blade, they are much less likely to find a different knife, right? They certainly could, but removing those preferred or fantasized methods really has a tremendous impact on decreasing suicide risk, right? It's best to remove everything, but that's also often unrealistic, right? Especially for adults who live alone. They may need access to medication or certainly knives and things like that for cooking. So we can't make the environment completely safe, but we can make it safer. So this is a very collaborative process. We want to reassess often. So I'm constantly asking about environmental safety every time the person's coming in. Often we can use blister packs, smaller over-the-counter medication bottles, often with clients who have thought of overdosing or a history of overdosing, 1-week dosages of medications, or having a support person store medications and they only have a pill bottle with a week at a time can be really helpful. And then specific means restriction, which really is this idea of if someone has that one knife or that one belt or that one place, that one road, if they're thinking about driving, then avoiding those things can greatly reduce risk. And we want to involve supports. Also adding visual reminders of reasons for living or that it would increase connectedness to the world. I had a patient who had a picture of her family and her reasons for living in her knife drawer. So it was just sitting there in her knife drawer just as a reminder because she couldn't remove all the knives from the home, right? We think about suicide deaths by method. In the United States, firearms account for the majority, 53% of deaths by suicide, followed by suffocation and other poisonings. And I think that's really important to remember and to just think about with clients. There are multiple methods and we can have a great impact in this. With John, we do need to do some lethal means restriction here. So the provider says, John, you mentioned you had the wish at times to shoot yourself. Do you own or have access to firearms? John, yes, I own 2 handguns and a shotgun, but they are important to me and I'm not interested in removing them. I completely understand. Let me ask you this. When your daughters are over, do you secure your firearms? John responds, of course, guns are dangerous for kids. I would never want anything to happen to them. Provider says sometimes guns can be dangerous for adults also. Research shows that limiting access to dangerous objects saves lives. I know that in our time together, you have started to identify ways to manage these suicidal thoughts, and we have created a good safety plan. However, in a moment of crisis, if you were in danger, wouldn't it make sense to secure your firearms like you do for your children? You are making sense, but I don't want to never have them again or sell them. Is there a friend you would trust to take them only temporarily until you could start working in treatment to decrease the suicidal thoughts? What about your battle buddy, Mike? I imagine he knows how to handle firearms. Yes, Mike would do it. He's been worried about me. Great. Would it be okay if we called Mike together now and talk with him about the safety plan and taking the guns temporarily? This would provide you with the maximum support. Okay. So there was a question about refusing to remove firearms from the home. It is really challenging. Often when I think of it as not a removal, but as a safety or protective measure, just like this illustrated with John in this scenario. In most cases, people are pretty receptive. If not, when people haven't been receptive, and sometimes they aren't, I've used gun locks, I've encouraged gun locks, anything that will delay access. So if I can decrease the time from when the person has the suicidal crisis to can access a loaded firearm, the better, right? So even things like having the bullets and the firearms 2 totally different places that would take 30 minutes, right? Or would be really hard, or through multiple locks. Those things can all help decrease this access to lethal means if the patient is unwilling to remove them from the home. I do highly recommend when it comes to lethal means counseling, the counseling access to lethal means on the SPRC website, and I'll include the link in the handout that I provide, is an excellent training that really talks about doing this. It does have to be collaborative though. We do need to work with the person and involve supports if possible. So if I have a patient who's unwilling to remove firearms, I might say, can we call someone who's living in the home or a friend to check in on you more frequently, right? Things like that. Hopefully that answered your question, Alice. Depending on your agency policies and your state guidelines, there may be alternative options. I know some districts, states, you can call and law enforcement will remove firearms. Others that may not be possible, and that may be clinically not the best scenario too. It may cause too big of a risk. So I think we're always balancing safety and can we safety plan first and get the client on board with a safer option versus taking away someone's freedoms in that way is always my first inclination. Okay. Checking on time, and we're actually doing okay on time. Yeah, if anyone has questions about what I've covered, feel free to just type them in chat. Okay. So we've covered identification, suicide risk assessment, brief intervention and safety planning, lethal means restriction, and now we need to look at level of care determination and referral. when we think of treating suicidal behaviors, in my mind, it is vitally important that we utilize the full spectrum of level of care. Inpatient being the most restrictive, to no treatment being the least restrictive. And just like any other medical or behavioral health disorder, people are harmed when their treatments are not the correct level of care. And what I mean by that is I'll use something like diabetes, right? So a medical condition. If a person has diabetes and they don't need insulin, they just need diet, and I treat them with insulin, I'm not a healthcare provider, but I imagine that could be harmful, right? Or if someone just needs physical therapy, but we hospitalize them, that could be harmful. People need to be treated in the correct level of care to receive the maximum benefit. And the same applies for suicide, where we need to utilize the full range of treatment options. Most individuals who experience suicidal thoughts and feelings are treated in the outpatient world, and that is the appropriate level of care. When to hospitalize? I think often there's a gut, maybe not gut, but there's an instinct that if someone wants to die, the best place for them to be is in the hospital. And the research really doesn't show that to be true. For this reason, hospitalization for suicidality is not treatment, it is stabilization. And as someone who worked in hospital settings for many, many years, I can attest to that, right? So when someone is acutely suicidal and they need 24/7 hospital support to stay safe, then yes, the hospital might be the right place for them. But if they are just having suicidal thoughts, the hospital is not going to help them because it is not treatment. It's not suicide-specific treatment in most cases. Also important, hospitalization may increase the risk of death by suicide. One of the highest times for death by suicide is following discharge from a hospital. Hospitalization, especially involuntary hospitalization, damages the working alliance and often reinforces where the person then is not truthful about their suicidal thoughts, especially if they have a negative experience in the hospital. I think hospitalization also may inadvertently reinforce to the patient that they are not capable of solving their own problems. And that, in my mind, is probably the most harmful part of this. We want people to feel confident and to say, I can get through this crisis, right? With support, with a safety plan, I can get through it on my own. If we're always wrapping people in a bubble and taking them out of their lives, right, to solve the problem, then we're actually communicating your problem is unsolvable. It is not solvable if it requires a hospital every time. So I think that in my mind, to answer inpatient hospitalization, it's the last resort. And I communicate to patients very clearly. It is the last resort because we're going to find some other strategies. When to hospitalize and when to safety plan, there are times when I do hospitalize, specifically if there's secondary symptoms, so psychosis, acute exacerbation, intoxication, medication side effects, or health problems. If they are in that acute suicidal crisis, meaning I and the patient believe that they are going to attempt to end their life within the next 24 to 48 hours, is what I consider acute, unless I can safety plan, right? So if I can safety plan even in that intensity, then I may not hospitalize. And sometimes we've just exhausted all alternatives. One way that I help patients work through, and both for myself and patients about hospitalization, is I think of any treatment that we engage in with a patient, we have a risk of side effects, right? Talk therapy has side effects. Certainly, any medication that you might prescribe has side effects. And the same is true of hospitalization. So I think of hospitalization versus safety planning. I'm thinking of the pro and con list, right? We're hoping for positive outcomes with either safety planning or hospitalization. But I'm really looking at, okay, what's the pros and cons? What's the potential side effect between these two choices? And then collaboratively with the patient, which makes the most sense. And I use this and I'll walk this through with patients. I'll talk to my teams and supervisors about it and say, okay, where are we at and what makes sense? And it really has helped me manage my own kind of pull at times to want to hospitalize when I really look at the bigger picture and the wider context of, does this make sense for this person right now? So this is an individual process for each client. Hi. So we want to determine disposition, level of care, and then we want to follow up. So our possible dispositions for John, right, really are emergency psychiatric evaluation. So we could send John to the emergency room. We could safety plan with a mental health referral appointment within 7 days. We could do a non-urgent mental health follow-up, or we could say no further intervention is necessary, right? For John, when we think about what we've done with him, he's opened up about having suicidal thoughts. He's not denying suicidal intent now. Denying plan does identify an identified method, right? But we were able to safety plan his buddies coming to get the firearm. He has a good safety plan. And he expresses a desire to want to solve this problem. And I think for me, the desire for living seems to be a bit higher than the desire for dying. Now, we have no way to assess. We can't predict who will or will not die by suicide. But everything that I'm seeing with our completion of that ASQ and safety planning and his engagement indicates that John is not at imminent risk of suicide, right? And the evidence for that, he was engaged in safety planning, lethal means restriction, but he does have significant risk factors: increased hopelessness, pain, sleep problems, psychosocial stressors, and daily suicidal ideations. So my disposition recommendation would be safety planning and a mental health referral within 7 days. And John agreed to outpatient therapy, and we scheduled in clinic an appointment for the local VA for May 30th, 2025. If we do that kind of safety planning and mental health referral, research really shows that appointments within 72 hours, 5 days, 7 days, not business days, calendar days at the tops, is best practice. So we really need to, if we screen someone in our healthcare office, discharge from the hospital, we need to, if at all possible, get an appointment within 7 days. If that can't be with a mental health provider, it can be with another healthcare provider or primary care physician. And then we want to really communicate that. So we want to engage in collaborative caring contacts and referrals. Really important, HIPAA allows for communication between professionals even without a release from the patient to assess acute suicide risk. That is really important. It's only about suicide risk. So I can follow up with John's new provider at the VA send referral regarding his suicide risk to that next provider to ensure that they are aware of what we've done, of the safety plan, of the, lethal means restriction, and that becomes really, really important. We want a referral within 7 days. And then this is something that's really interesting that research has shown. Caring contacts, which is really sending periodic caring communications. That could be postcards, email, text, voicemail, for 12 to 24 months, in addition to regular treatment after hospitalization, suicide crisis attempt, or significant loss, has a major impact on reducing suicide attempts and deaths by suicide. So when someone discharges from acute care or has a transition in care, if we just send them a postcard, just, hey, thinking about you, we are here, that tends to have a huge impact on decreasing suicide risk. And then we want to always have support for professionals. This work really can be quite taxing and be hard. So I really think that the more that we can support each other, talk about this work, get additional training, and consult. I rarely make a decision without consulting with someone else. So I'm always checking with my team. It's why I love interdisciplinary teams so much, is that we can check with each other and say, does this make sense? Yeah. And I do just want to acknowledge that if we're working in healthcare, there is a risk. It's the hazard, right? The hazard of doing this work and working in healthcare is that we will at times lose patients, sometimes to health problems, sometimes to suicide. And I think that that's a hard thing. So I really just want to acknowledge that losing someone, especially to suicide, can be very taxing. And I think we just continue to engage. And I just remember that, I've lost too many patients to suicide, but many more have learned to fight, live, and love. And I think that that really is what pushes me through. And that losing someone to suicide does not negate the positive impact that they had on the world. It's not an end to their story. And it doesn't, I think of it as it doesn't mean they didn't make progress just because they lost the battle that day. And I think that's really important for us to remember too, when we make mistakes, when I'm not as empathetic as I should be. Just because I had a bad day doesn't mean I lost the battle, right? We've got about 10 more minutes, so I'm happy to answer any questions before we kind of take a break and then come back to Q&A. I feel like I just did a whirlwind of talking, so yeah. And I guess maybe thinking about if you're joining us for the next hour, where we will dive in, if you wouldn't mind either unmuting and talking or putting into chat what you want to dive in more into, or what I can, expand on, or something different that we didn't talk about. I would really be interested in knowing how to structure that.
So Anna, I'm not sure how I asked this question, so I hope you'll help me if you can understand what I'm trying to ask. But so I have been around suicidal people a lot. I don't know what that says about me, but I've worked in the field for a little while. But I hear quite often the reason that people stay around is because they're living for this person or that person. And my thought is, okay, that's great, but it also puts a lot of pressure on a person, especially children, whether they're older or younger or what have you. What is your, and especially spouses, what is your thoughts on that?
So, yeah, I think I know what you're saying. So that someone's saying I'm alive right now because of my kids need me, or I don't want to hurt my family, right? And then
Yeah.
the family feels this tremendous pressure, right? Of mom's,
Or a spouse.
yeah, spouse is only living for
Yeah.
me, right? And they're in so much pain.
Especially, so I'll just tell you, had a friend years ago, and she was actually planning on divorcing her husband, and he didn't know at the time, and he lost his job, blah, blah, blah. Well, then he became suicidal, and his reason for living was his kids and his wife. Well, that kind of threw her plan out the window, and she stuck around because she felt like she was keeping him alive. And that's when I really started realizing it puts a lot of pressure on kids, on one, now the kids feel like you gotta stay with dad or mom or whatever. You know what I'm saying? Because they hear the mom or dad. So I'm just wondering, what are your thoughts on
Yeah,
that?
I'll say this. It is really challenging, but people do not die by suicide because of one thing. And when we think about the suicidal crisis, right? A lot of times we think of it as this was the thing that put them over the edge. But it's not. It's like a bucket in the middle of the field and rain's dropping and it slowly fills up until eventually one drop causes it to overflow. And that one drop might be I hung up on someone. I canceled thinking of me as a clinician. I didn't return that phone call fast enough. I canceled an appointment. That might have been one of the drops, but it's just one of all the drops. The
It's not the whole
same
bucket.
applies for reasons for living. I have no research to back this up, but from my own experience, lived experience of having been suicidal and my loved ones, and certainly clients who are suicidal, there are many reasons to stay alive, not just one.
Right.
No one's surviving for just one thing. They may verbalize that, it may feel that way, but I have seen that one thing go and the person find another reason. Humans are really built to survive. It's quite miraculous, right?
Right.
And so I've seen where that one thing happens and there's another reason. And part of it is the human will to survive, right? Which is pretty powerful.
Okay. Thanks.
Yeah. You all are a quiet group, and I don't know if that means that there's just you all are absorbing. That's what I'm telling myself. That's the story I'm telling myself. But I would, if you're open to it, I'd really love to know what to focus the next Q&A, or just, I guess, encourage you all when we come back at, yeah, tired. Yeah, no problem. When we come back at, it'll be 3 o'clock, I guess. Then we be thinking about what you want to ask. It could be related to what we've talked about or just about suicide in general, or about how to engage in these practices more specifically in healthcare. So, yeah, it is a lot to soak in, Haley, for sure. Oh, and we definitely kind of ran through um, John's case, which uncovered a lot. Well, I think what I'll do, Lisa, is maybe prepare some general guidelines of like resources and things like that. And then hopefully when we come back at 30, people will have lots of questions. Or if you have any questions for sure, we can just have a conversation about how do you apply all this stuff and what do you do? The slides won't be shared, but you'll get something better next week, which will be a handout with much more detailed references and select slides. So I found handouts to be much more beneficial and usable than slides where you don't know what they mean. So that's how I experience big PowerPoint presentations.
And also, this training will also be on our website as well.
Oh, good. I'm so glad, Donna, that you enjoyed the training. Okay. Well, Lisa, should we wrap up and then come back in 30 minutes?
Yeah, that sounds good. We'll come back at 3 then. Thanks, Anna. We'll see
Perfect.
you at 3
Thank
then.
you.
Uh-huh.
feel like I'm like, okay. Oh, you don't need to record right now, but I'm just I'm gonna show some videos, I guess, for the second part. Unless people have a bunch of questions, but I feel like we're all just kind of, oh.
The reason I know I don't have a lot of questions is because you're answering all the questions every time I think. I'm not kidding. Now, people can say otherwise in the chat, but I know every time I think, oh, I got a question, and I'm even. I was I was gonna look at my notes. Every time I start to think I've got a question, you'll answer it, and I'm like, well, there goes my question. So it's like. And maybe I'll have some like tonight about 1 o'clock in the morning because I go to bed at 7 o'clock. Well, I nod off on the couch. But really, Anna, I'm not one to just throw out compliments unless that's just who I am. But you really are covering this material really good, and I greatly appreciate it. So,
Well, thank you. Well, and it's been from, I will say I present a lot on suicide and to different providers and teaching, and it's through people asking questions and saying, hey, this didn't make sense, that I've made changes. So I always adapt and change every time. So
Can I ask a question, not in the chat? I was just thinking about like kids and suicide and like suicide prevention in children, because sometimes you encounter them and they become very impulsive. Like they may be fine and then they're like suicidal. Like I don't know how to frame the question, but just talking more about children.
got it. Yes. What I'm doing right now is I'm pulling up some stuff about kids. Because yes, I would say the main aspects are very, very similar. There's not much shift besides that I'm much more intentional about utilizing supports.
Because like you also talked about like they're thinking about suicide because of like a problem, but sometimes kids can't change some of the problems that they encounter, have no control over that.
Yes. So it is a lot more about safety planning. And there are some specific treatment interventions. So DBT works really well with adolescents for sure, less so for kids, but CAMS care is has CAMS for teens, and then they're working on CAMS for youth as well. So it really is about getting the whole family involved, in using more systems-based can be really effective as well. So often getting the whole family aligned in preventing suicide when possible. Sometimes, you know, some caregivers are not willing to engage, but I found similar to like firearm removal, when you talk about safety and prevention, most people are willing to do something, even if it's not the preferred, if that makes sense. Yeah, just looking real quick. Okay. Okay, should we get started, Lisa? Good. Okay. Thank you all so much for hanging in there. I know a lot of you have been here all day with me, and it has been a lot that we have covered. I do want to address, so I got a few comments, and feel free to direct message me also in chat if you prefer to expand more on chronic suicidality, talk about adolescents and kids, and then a comment on physician-assisted suicide. I'll address the physician-assisted suicide or medical aid in dying. That is beyond the scope of this presentation. I do absolutely have thoughts and feelings about that, but it's very hard to distinguish. In my mind, it's almost two separate things from suicide prevention and my suicide prevention efforts. So I really keep them separate in my mind. And I'm still figuring out, I guess, how I feel about medical aid in dying. So I don't have much more to add besides it's complicated. And I'm still figuring it out. And I do know that there's a great deal of disagreement and I would say maybe disconcern, I guess, within the suicidology field. Yes, the verbiage makes things muddy, and it's just, we don't know enough yet. We don't know enough about the impact while medical aid in dying or physician-assisted suicide has been legal in some states in the United States for many, many years. It's unclear what the impact is or what the difference is between suicidal ideation as we think of it. I will say one thing, which is in my mind, those are two separate states. My clients who experience suicidal thoughts or desire, it is not necessarily because they want to be dead. Being dead is the only option they see to escape pain. But when I ask if things could be different, right? Kind of that miracle question, if things could be different, would you want to stay alive? Most will say yes, right? That's very different than clinical presentations that I've worked with for people maybe on hospice or who, are considering medical aid in dying due to an incurable illness where they're trying to prevent future pain. They know things are either so painful right now and going to get worse, and they're trying to prevent that suffering versus suicidality, which in my mind is I'm suffering right now so severely and I can't see a way out. But if I did have a lifeline, I would, right? And that's what I see over and over with clients is if they think they're holding on to, right? That's something, if I get the job, someone loves me, someone sees me, witnesses my pain, I can hang on longer. Very different than the desire to actually not be alive. So I will say that, but then, yeah, it's complicated. I just had to gather my thoughts real quick. Well, maybe I'll share my screen. Please continue to ask questions. But I wanted to kind of wrap up this session and then maybe talk a little bit more about the purpose and function of the suicidal wish and this idea that I talked about in the first session with chronic suicidal presentation and how that shows up and how that's different than acute or time-limited circumstantial suicidal presentation. And I think I can illustrate that with John. But let me share my screen real quick. Go. And thank you all for your patience with shouldn't say anything about tech now that we're almost done. We don't want any issues. Okay. So let me get chat pulled up. Perfect. Okay. So in thinking about the zero suicide movement and the best practice steps, in thinking about how we can apply this, I really think whether you're in healthcare, a peer recovery support specialist, or in mental health practice, applying these best practice steps throughout is the way you apply it. So it really is intentionally thinking about suicide, screening everyone for suicide risk. If they screen positive, doing a more thorough suicide risk assessment, making sure to empathize, engaging in safety planning and brief interventions, environmental safety, which is lethal means restriction, determining the appropriate level of care, following up, and then making sure that we have support for ourselves. And I think the one difference in behavioral health care would be then we would be determining that level of care and providing that suicide-focused treatment. I talked a lot about chronic suicide versus acute suicide. The distinction there really is that the acute suicidal crisis is that short period of time, usually 5 to 30, at the max 60 minutes, where someone has the sudden desire and intense need to act on suicidal impulses. And that's where our safety planning and connectedness really plays a big role. But people also have varying time frames of when they have suicidal thoughts. So it is not uncommon, for example, for some people to have suicidal thoughts that occur when they are intoxicated by alcohol, right? And that's the only time that they have suicidal thoughts. In my mind, that would not be a chronic suicidal presentation. It would be, hey, maybe your mind is allergic to alcohol for whatever reason, right? So maybe drinking is not the safest thing for you. Other people have episodic suicidal thoughts where there's a period of time in their lives, usually associated with some stressor. Maybe that's the loss of a loved one. That could be loss of a job or relationship or any type of pain that is episodic. So meaning there's kind of a trigger that creates the suicidal thoughts, and then it persists, and then they go away as that trigger, the source of pain is resolved, or the person learns to manage in a different way. And that is the most common presentation of individuals that I see with suicidal thoughts. And a thorough risk assessment really can delineate how long have you had this, right? So I'm always asking, when did you first have suicidal thoughts, and do they occur under certain circumstances? It's not uncommon for people to experience suicidal thoughts, only for women to experience it during their menstrual cycle, for example. So with those hormonal changes, the suicidal thoughts increase and then they go away completely. So hopefully that makes sense about kind of the time frame where it's really there's some identified trigger and that increases the suicidal thoughts. And I'll share more about the suicidal mode in just a moment. But I wanted to show this brief video about why people have suicidal thoughts. And this is based on I'm blanking on the name of the theory, but the video will share it. So I'll share this video right now.
If you're a person who has suicidal thoughts, one thing that might help make sense of it is the stress model, or Linehan's stress model, or the biosocial theory. What it does is it explains why somebody would want to escape. Because what it shows is that some people have more intense emotions, more painful emotions, and that anybody who's having really strong and painful feelings often wants to escape those, wants to get away in any way that they can. And our brains learn all sorts of ways to get out. Those can be things like drinking, using drugs. Sometimes it's eating. Sometimes it's, distracting yourself with running or exercising, other types of exercise. But sometimes it's suicidal thoughts. And there's research evidence to suggest, there's some research that shows that having a suicidal thought can actually make you feel less bad. That is to say that if you're somebody who tends to have strong emotions and those emotions really wash over your whole body and are really intense, if that's you, then your suicidal thoughts make sense because it's your brain's way of trying to get an escape from feeling so bad. And the good news is that when we think about it that way, we can start to find other ways to manage those intense experiences, to both prevent them, to manage when things are getting more and more intense, then to manage the hottest place, and then to manage afterwards. The DBT skills help with each different phase of that. And over time, they also help with the intensity so that you get to choose how you react in situations so that you can, if you want to feel that way all the way, you can go for it. If you choose not to, you can not go for it. You can do something else. That's the biosocial theory. And it helps explain why people do the things that they do and why they have suicidal thoughts sometimes.
Wow. So in thinking about that, right, the biosocial theory or Linehan's stress model, I think that's a really good explanation of this idea of why people have suicidal thoughts and how it can create relief for people. And I think that when we think about it that way and we can explain it to patients, in my mind, it makes it less scary for me. So we started off the day earlier really talking about our own reactions, and often for medical providers, when a patient is struggling with suicidality, we often feel very scared, nervous, anxiety. We don't know what to do. And when I can understand why that person's feeling that way, it helps me feel calmer too, right? So that understanding. The suicidal mode really is what we're assessing. So this is where I think of when we think of the difference between acute and chronic. So really, every person has a baseline risk of suicide, right? And it's encompassed by cognitive, right? How we view ourselves, how much flexibility we have cognitively, our problem-solving abilities, right? So if I believe I can solve this problem, or I can solve most problems, I'm much less likely to move towards needing to escape via suicidal thoughts. Our emotional risk levels, certainly, while suicide is transdiagnostic or adiagnostic, it certainly is increased by some psychiatric disorders or that emotional intensity or emotional liability. I can never say that word. Intensity, emotional intensity. We also have to pay attention to our physical, that can increase our risk, right? Our genetics, medical conditions, our demographics, our trauma history, and pain, all of those things. So we think about it, my risk of suicide right now is significantly higher than it was when I was 10 years old, only by virtue of my age, right? our suicide risk increases the older we get, just statistically. So thinking about that alone, the older I am, the more at risk I am, right? And then certainly other demographics can increase that baseline risk. Behavioral, certainly prior suicide attempts is a strong predictor of future suicide attempts. Our kind of capacity, right? Thinking about that capacity. So we all have this baseline risk. When it comes to chronic suicidality, that baseline risk is much higher, right? So people with chronic suicidal behaviors typically have more cognitive, less cognitive flexibility, more kind of certainly ACE scores, and more struggles that place them at higher risk initially. And then you have these activating events or stimulus that create these suicidal crises. And that's where you shift into an acute suicidal mode versus just your baseline risk, if that makes sense. And for me, this really is the purpose of assessing. So whether you're doing a quicker assessment like the ASQ or a more in-depth narrative or Columbia assessment, in my mind, what we're really assessing is this, that baseline risk, and then what things may increase that risk. Another way to think about it is the suicide risk categories, where the baseline, there's is still at risk, right? But there's no stressors, and the person may just have passive ideations. And then it just moves up. So usually for my patients with chronic suicidality, which has persisted often for a lifetime since early childhood, they are usually in category number 4. I think it's important to think about the purpose and function of the suicidal wish. We talked about why people have suicidal thoughts, but that it actually serves a real purpose. It actually is a strategy to obtain nurturance and connection. And this is where things get really challenging. So before we went on break, Lisa asked a question about the burden that when we care about someone who experiences suicidal behaviors, that we can feel like we can't do anything, right? We can't maybe set boundaries, or we have to sacrifice ourselves because they require so much attention. And it can certainly feel that way at times. Because they are using at times, right? They require more attention. I'll just say that. And they're trying to seek that in other ways. I especially see this with children and adolescents. And this is where parents and teachers can get really frustrated when the child is continuing to engage in threats of suicide or suicidal behavior, self-injurious behaviors repeatedly. It can feel like it's just attention seeking or that they aren't serious. And I think that can be a dangerous stance to take. I think we need to take it serious and maintain appropriate boundaries, right? So I don't get people don't get off the hook, but I am taking their cry for connection and their distress seriously, and helping them find more pro-social ways to ask for connection and the care that they need. Let me know if that doesn't make sense, because it is a little confusing. But the goal is it's to increase the self-reliance of the person and not create more dependency. the suicidal wish really is, it's a symptom or a coping strategy for pain relief. So it's both a symptom of pain and relieves pain. It provides a tremendous sense of control. I think especially to individuals, especially adolescents or people who just feel really stuck or like they have no control or they don't belong. They can always end their life, and that provides a tremendous amount of control and self-efficacy. So my goal then clinically really is to help them find other ways to gain control, just like I would if I were thinking of trauma treatment, right, or trauma-informed care, where this idea of control and making sure that it's a shared power dynamic, I think also really applies to suicide prevention. I think there's some really commonalities of suicide. So its purpose is to seek a solution. The goal is cessation of consciousness. This is from Dr. Schneidman, but that's different than medical assisted death, right? Where the goal is death. This is a desire to not think or feel, right? And so one way to think about it, the difference is that if I can help them think or feel differently, that has the same result, if that makes sense. So that's really how I apply it, is thinking about how can we decrease your suffering and improve living. The cognitive state is often very ambivalent, and the emotion is hopeless and helpless. And it can be a really constrictive state, meaning that individuals who are experiencing high levels of suicidal intensity often really struggle to see a full range of options. Like I said, that frontal lobe kind of goes offline. And so they really need our help, whether it's a family member, a peer support, just someone listening to them, to help them see that there may be other options that they just can't see of it in this constricted state. I thought it might be helpful as we move through, but please, if you have questions, I definitely want to have your needs met. But this is a brief video. It's about 1:30 of a individual talking about her experience with chronic suicidality. So I thought this might be a good thing to show.
I'm suicidal, and no, it's not what you think. I'm safe. I do not have a plan, but I'm suicidal, and I can't remember a time when I wasn't. People think of things like suicide in such black or white terms. We are so quick to place every experience and feeling into categories. But being suicidal falls into a gray area for me. I don't have to be spiraling into chaos to be suicidal. In a room full of the ones I love, deeply immersed in my passions, these thoughts can still linger. I wake up most mornings thinking I'd be better off dead. I feel it, but I try not to give power to it. Throughout the day, I am faced with challenges that directly affect my subconscious. Either the suicidal thoughts get louder, or they remain a feeling aching deep in my bones. I should explain. Sometimes being suicidal is different than suicidal thoughts. It's a feeling that you have an itch that you can't scratch, that a dark cloud is shrouding you. It's anxiety and depression. It's a mixed state. You're drowning, there's no air, and coming down from that feeling takes so long you think it's impossible. The only way to survive is to push through. While this is happening, you go through your day, as normal as you can, without feeding the festering ideation. The way I feel isn't a reflection of my reality. I know I have things to live for. I know things can get better. I have people I call family, some blood, others through spirit, and the people who don't like me don't matter. I know these feelings will eventually pass. Life would be simpler if my mind and body would work towards getting better, together, in harmonious unity. I started making plans.
I'm going to pause this right there, but I will include the link to the video in the handout. But I think that this is a perfect illustration of the difference between the persistent wish to die, or these periods that people experience, these kind of situational periods where people have this strong suicidal intensity, is a good way to describe it, while continuing wanting to live. So it is almost this kind of split self of both wanting to die and wanting to live simultaneously. And when we can think about suicide in that way, then we can really engage with the suicidal wish and provide more effective suicide-focused treatments. And a good way to kind of think about this is certainly empathizing with the suicidal wish. But really, in our minds, we recognize that suicide makes sense when viewed in the context with this person. We want to listen, validate, and empathize. We also need to recognize that the person is in this mode of cognitive constriction. The way that I describe this to clients is like a dark colored sunglasses, right? So if you're struggling with suicidal intensity or depression or addiction, doesn't matter, and you put on dark colored glasses, the entire world looks darker. You can't see the blue. You can't see the sky. You can't see the full range of options. Even though in your mind, you know that they are there, you can't access them right now. And my job then as their provider really is to get them to trust me enough or trust someone enough that they can hold on to believing that there's a world without that darkness, right? And that really is that kind of therapeutic alliance and the work that happens from empathy. So I really explain that to patients. I say, you've got your dark colored glasses on right now, and you can't see another option. Can you see or trust that another option may be there? And when clients can say, yes, I trust that you see it, I don't feel it right now, I find a great deal of relief from them, because they're beginning to recognize how constricted their cognitive thinking is. And then we have to maintain hope. I think that is the foundation and often the hardest to do. If we can maintain hope and remain committed to recovery, and we have to express that to the person. I'm always surprised about how often I hear from patients, whether it's they have chronic suicidality or not, things like, well, I knew I was seeing my doctor today. I knew I was seeing this appointment today, and that got me through. That commitment, or knowing that someone was counting on them or believed in them is what got them through maybe a tough night of suicidal intensity. I'm going to pause real quick to see if there's any questions or anything I didn't follow up on. No, I'm just thinking there was a question about, okay, how do we apply all this, right? I've talked about all these things. How do we do this? I think you just start thinking about suicide. Find a suicide assessment tool that works for your organization. a screener, something, one that fits with you that you like, and start using it. Start using it at every intake. Start asking about suicide, thinking about suicide first, and then working with patients and helping them, just listen to their suicidal experiences. And I think you'll be really surprised at how, when we're more open to being willing to talk about suicide, how often your patients may have suicidal thoughts that you were unaware of. Whether you're a primary care provider or a behavioral health provider. My suspicion is that it's even more common than we know, and it is extremely common. I think just a reminder of how we think about the therapeutic assessment. I said pick one in your handout. I'll include a bunch of different standardized assessment tools that can be really good. But really thinking about how we can use therapeutic assessment as we would any other diagnostic or clinical or medical assessment, right? Where we're really normalizing and then focusing. I think some general assessment tips, I thought that that might be helpful. These can be things that can be done in any care provider setting. So this is not specific to behavioral health care, but it really could be any medical provider. Using gentle assumption really is assuming that the response will be positive. Too often with suicide, people use the opposite of gentle assumption. So an example of that would be a patient comes in, maybe to their primary care like John, and is reporting, think of that first question where John didn't ask number 9. It would have been a very different response had that medical professional said, "You aren't having suicidal thoughts, are you?" That preempts a negative response, right? We're assuming that the answer is no, and that's often how we ask about suicide, about many things. You don't use alcohol, do you? You don't use drugs, do you? Where it can be really, this both is shame inducing, right? So a positive response can feel shameful to the person. So a gentle assumption really is what the medical professional said, which is, you've been having a lot of pain. I wonder if you're having suicidal thoughts, right? I see you've been struggling. Have you had suicidal thoughts? Very different. Or tell me about the last time you had suicidal thoughts, right? Where you're just assuming it's an affirmative response. That can really help attenuate that shame. Denial of the specific really is when we're assessing for lethal means or method, where we ask specifically. It's much harder to deny. It's easier to say a blanket no versus, have you ever thought about overdosing? Have you ever thought about using a firearm? Right? So it really is going through the list of possible methods. Symptom amplification is something that's really used in substance abuse counseling, which is very effective, but also can be used for assessing suicide. It's where you push the symptoms to the highest end, right? So if I'm asking about past suicide attempts, right? And because of the shame of suicidal behaviors, people tend to minimize. So instead of, if someone says, have you had past suicide attempts? Yes. I might say something like, how many times have you attempted suicide? 75 times? Yeah. I'm much more likely now to get an accurate response, right? It might be 10 times versus a few times. So that symptom amplification, or how intense are your suicidal thoughts? Do they happen 10 hours a day, 12 hours a day, right? We really want to get specifics. I talked about asking about other plans, asking what prevented them from acting, right? What stopped you from attempting suicide? Often we're afraid to ask that because we feel like people may talk themselves into it. It's actually the opposite that happens. The more you allow people to talk about why they want to die, the more that they actually find reasons to live, in my experience. And we want to ask future-oriented questions. Although having a future does not necessarily mean that there's not risk of suicide. When we think about the suicidal crisis, it is so time limited and impulsive that it's impossible to predict. But it does give us a gauge about safety planning. Professional collaboration, because we kind of ended with John and collaborating. I think it's really important that we get ongoing consent every time. What that means, if I have someone on a release of information, I'm still checking with my patient every time I reach out to their prescriber or their primary care provider. We also want to get consent for any routine assessments every time. We can really play a strong role in advocating across interdisciplinary teams and managing the different clinical options. And often we are providing advocacy with prescribers or primary care physicians. If someone does go inpatient, and we talked a lot about kind of the pros and cons of inpatient hospitalization, but when you're in a medical setting or a behavioral health setting and your patient does go inpatient, it's really important to understand the hospital's policy regarding other clinicians providing treatment during hospitalization, and if possible, know your hospital's policy so that you can communicate that with the person. Hospitals can be, I've certainly seen a lot of success with hospitals, but they can also be very re-traumatizing to clients. Thinking about because it's such a protected, clients often have to have a full body search, which can be very traumatizing. Depending on the hospital, they may lose access to their phone or their music, some of their main coping strategies, and certainly lose connection with loved ones at times. So I think that can be recognizing and preparing your patients if you are sending them to the hospital and they need to go to the hospital, helping them prepare for the differences between a psychiatric hospital. It's very different than going to the medical hospital, where you can wear your own clothes and have your cell phone and have visitors any time of day. Psychiatrics are much more restrictive and you're locked in most cases. For good reason, but it is a difference. So I like to explain that to my patients. We really want to follow up on any records requests, like I talked about with HIPAA. We want to offer to collaborate with the hospital inpatient psychiatric or clinical team. And following discharge from the hospital, if you're continuing care with that person, we really want to get an appointment, ideally within 24 hours, if not 72 hours. That becomes really critical because when someone's discharged from the psychiatric hospital is the highest risk point for a subsequent suicide attempt or death by suicide. there was a question about adolescents, and we do know that adolescent suicide is the #2 cause of death in the United States, and really globally at this point. It is certainly, adolescent suicide has increased quite substantially over the past 10 years, especially. And we don't quite know all the reasons why. There's certainly, yeah, I mean, thinking about social media, there's been lots of research about social media, found that it's both protective and can be a risk factor. But there is definitely something going on that's increasing suicidal intensity for adolescents. I know that during COVID, when schools went online, there was, although the suicide rates, so death by suicide decreased quite a bit during that time, suicidal intensity in emergency room visits increased, at least in the Western states, and the data is still being analyzed nationally. But I think that that's important to know. But when we think of treatment with adolescents, family therapy really can be very powerful, and I think it is a system problem. So it is both providing individual assessment, and I assess the exact same way that I just have described this entire day. So I'm doing a suicide assessment with the adolescent or child. The Columbia has child measures for suicide risk assessment. I'm doing suicide focused treatment plans and doing safety planning with all ages. I've even done a crisis safety plan with a 5-year-old child, so as young as 5, where we're really looks a little different. And obviously, anytime I'm doing a safety plan with a minor, I'm involving the caregivers as much as possible and legally permitted. But really with family therapy, we want to identify the unresolvable problem that results in feeling there is no way out. And that often starts with family therapy, and everyone getting on board to decrease suffering, both for the individual experiencing suicidal thoughts and the family as a whole. So my goal then is to increase families' coping and problem-solving strategies and to increase flexibility. And then addressing opposition, aggression, and denial. And I think that that can be really hard. So often I'm working with parents and with the adolescent, or the parents are working with another clinician, addressing their own fears and their own worries. And there's a lot of good support for parents and caregivers who have a person who is struggling with suicidal thoughts. So I think that there is some new research and support groups for that are being developed right now, I would say. But there is some evidence-based treatments for adolescents, less so for children. That is a very under-researched population. As you can see, the last book about child suicide was written in the 80s. And so it is very, very teensy amount of research about young children, but we do know that young children do experience suicidal thoughts and do die by suicide. But really with DBT and CAMS for Teams are the two evidence-based treatments that are currently there for adolescents. And I think about like death fantasies is really what I mean by that, is really exploring with the youth what death means. And really, because kids can be so impulsive, especially younger children, and they may not have a good understanding of what death is. So helping them explore that. and helping them find other escape fantasies really becomes the goal. And then really a suicide focused treatment as usual, I would say from that point on, and really helping them develop those more self-efficacy and working on those suicidal belief system, whatever treatment intervention you're using. I feel like I've just given a whirlwind speaking, so I wanted to pause and see if there was any other questions or just thoughts that you all are having, or reactions to all of this work or content, I would say.
I think everybody's really taking it in. It's a lot.
It is a lot. I will say, when I first kind of shifted my thinking about suicide and what I just presented to you all here, I actually don't remember if it was someone said it or it was a culmination of thoughts. But when I first heard, don't prevent death, live life, or something like that, right? When I first had that realization that my job was not to prevent death, it was like both a mind-blowing light bulb went off. I've been doing this all wrong my whole life. And it was so freeing. Because when my focus, thinking of being a new clinician and working with trauma survivors and highly suicidal individuals, and I felt it was my job to prevent them from dying. That's completely irrational and magical thinking and impossible. And the burden, right, that I placed on myself as a clinician was just unsustainable. So when I learned, it was really through the assessing and managing suicide risk training and reading suicidologists' writing, and I realized I don't have to prevent death. I just have to improve life, right? And that really freed things up for me so much that I felt like now I have the capacity to sit with someone in this intense suicidal pain, right? Or as Dr. Linehan says, jump into that dark room. I can do it now because it's not my job to prevent death.
It's not your job to save somebody.
No.
Mm-mm.
No. It's my desire to help people save themselves. But I'm not that powerful.
And that word it's your desire, that phrase makes such a big difference. And trying to explain that to people, like my mother-in-law, when my brother-in-law killed himself, of course I wasn't going to say that to her after that happened, but she just kept saying, it's my fault, it's my fault. I didn't stay on the phone long enough. I should have, and I just don't feel like in the beginning, when something like that has first happened, you don't try to rationalize with people. You just can't. Now after many months, when we could actually have a conversation, then that is when I began to talk to her about it. You cannot stop somebody once they've made a decision. You can't. And that's when she was able to talk to me about things. And I said, you can't make a choice, just like I can't make a choice for you. And I did little simple explanations or examples. If you decide you don't want to clean up the house today, I can't change your mind. And she's, she kind of got that. But if I had tried to say that in the beginning, but I really like what you just said, Anna, about it's your desire to want to, change or whatever. People, whatever, stop people. I really like that. I like that a lot. I'll be writing that down.
Well, because I think for me, it's the balance, right? I have to be able to, I like the suffering is in the resistance, right? The resistance of, I think what that person's meaning is really that suffering is when we're resisting or trying to assert control we don't have. We're in that tension, right? That tension between the client's need to escape suffering, and our need to prevent suicide death, right? And I think that when we can expand beyond that and just have a new goal of improving life, the end result is my hope and my belief. I do believe suicide is preventable. I have to believe that to do this work. And I recognize fully that I will continue to lose people I love to suicide, right? Yeah. Both exist simultaneously. Yeah. And I think that's really the important piece. And I think that risk mitigation is, it's a hard thing. It's a fear-based practice. So I like to use more, while it is important, documentation and all of these things and following best practices and policy and procedures. I like to adapt them into ways that make sense and support me with my goal of decreasing suffering. So if I were to do safety plan as usual, a one and done, right? Then yeah, that would be risk fear-based, wouldn't be helpful to me or the client. But if I can use safety planning as a more of a collaborative exercise, and really meet the clients where they need and identify what do you need on the safety plan. And some of my clients have some bizarre things on their safety plans. Like it's sometimes cutting. I've seen cutting on a safety plan. And I'm like, oh, okay. Is that the best for right now? That's the best. That's the best way for them to decrease their suffering. So I do truly believe in a harm reduction approach. And with the goal of let's assess, is this really working? Is this really helping you? And over time, people begin to develop more pro-social coping strategies. Right. But if someone needs to do something else that's going to keep them alive and that's what they're willing to do, I'm not one to get in the way.
Right. They're alive.
Yeah.
And you can go back and look at that later, what they're doing. They might be dense, they might be cutting, but like you said, they're alive.
Yeah.
Yeah.
It is, but I want to just acknowledge, I know we're running up on like 5 minutes, but I want to thank all of you, truly from the, bottom of my heart, I guess, not to be too cheesy, but, it's been a fun, interesting day. And I think seeing your all's comments, and just feeling the virtual vibe, I guess I can feel it, I think is really powerful. And I just want to encourage all of you, take what you love about what I said, discard or find your own way with what didn't resonate with you. There is no one right way to do this. There are some best practices that I think are essential, but how we adapt them is really up to each of you, and your way of doing suicide-focused treatment will look very differently than mine. And I think that's a beautiful thing, because that means you will be able to reach clients that I cannot. And to me, that it really is the magic of this work, is that we're all in this together. And this work is hard. And I think that we suffer professional losses, and personal losses, especially when it comes to suicide. And the more that we can talk, and I'm so grateful to you, Lisa, for being so open, the more that we can share both our successes and our stumbles with each other, the stronger we will be. I think just like our patients who struggle with suicidal thoughts need connection, so do we as healthcare providers. We cannot do this work alone. And if we start to feel alone, that's when we need to reach out. We need to follow our safety plan. Because yeah, this work is powerful. It is emotional. And to me, it's the best thing I could ever do. So, thank you all so, so much.
Thank you, Anna. Does any have anything else?
Thank you so much, truly.
You are so welcome. And I'm looking forward, I'll put the handout together and get that to Lisa and the TSPN team. And then you all will have that. So.
All right, well, I hope everybody has a wonderful weekend. We got a nice long weekend ahead of us. And I just thank everybody for being here. Anna, thank you again. This was wonderful. We appreciate you so much.
Oh, thank you all so much. And yeah, reach out anytime. Connection is the most powerful tool we have.
Indeed. All right. Thank you. Bye, everybody.
Thank you.